Good morning, everyone. Welcome back to NextMed Health. This is day number 2, and we are coming to you live from Click Studios, and I'm here again with Shauna Butler.
Welcome to day 2
good
of
morning.
NextMed Health.
Yeah.
We are so glad. So many people have been joining us online, and this show is for you. So again, thank you for joining us, and please tweet at us or tag us at hashtag NextMed,
Yes,
NextMed Health. Yeah.
Yes, and we've been trying to respond to as many tweets as possible. I see here Rasu is in front of us, and he's been tweeting quite a bit, so thank you, Rasu, for doing that.
And
so,
if you hear a lot of noise in the background, that's because we're in the center, the epicenter of innovation in our innovation lab. We have over here on the side, we have people doing workouts with VR headsets, vrworkout.co, check them out. We've got people who are trying on, what else are they trying on?
I mean, there's all sorts of things. There's sensors all over this place. There's sort of a souped up EKG, ICU model that's out here. Yeah, there's plenty of activity going on right here in the lab. Lots of conversations and incredible topics. We have an exciting day ahead. Tell me about your night. How was? I think you went to the cacao ceremony, right?
Yeah. So first of all, dinner was fantastic because just the conversation and you could just hear the buzz. And I think part of it is people are excited to be back talking to each other.
Yes.
Meeting up with NextMed Health, talking with people who are pushing forward the change, listening to these new ideas that they had been exposed to, particularly around voting, around being
that was a powerful talk.
It was a system refugee with Dr. Alistair Martin, Stacey Chang, talking about system refugees, people who were trying to provoke change in the system and find themselves having a hard time. And then last night when we closed out with legendary Leroy Hood.
Yes.
Really revolutionizing.
What a legend.
Truly, but thinking about health and well-being in a fundamentally different way. So talk about a disruptor in the very best possible way. And then of course,
it was like drinking from a fire hose yesterday. I'm sure all of you experienced the same thing, but lots to take in, really exciting. It's almost like I was telling Daniel Kraft that it's like his slides have just come alive, right? Like everyone's diving deep into a lot of the stuff that he shares in his slides, and we've got a lot more today.
Yeah, and yesterday being able to do the Highway to Heal, does that not just look
that's so cool,
amazing? So today, people are getting very well versed in the lyrics to the 11 AC/DC remakes that have surgical and condition-specific lyrics, so that we can be ready for karaoke tonight. So
for those who aren't aware, this is a collaboration between Click Health and NextMed, where they did this album that's sort of modeled off of AC/DC's Highway to Hell. Except this one was called, which one? It was called
Highway to Heal.
Highway to Heal.
Yeah, some people might feel like working in healthcare right now is
Highway to Heal.
But actually, we really are on a highway to heal. So, but this was based on research that was done, looking at does music in an operating room setting, does it have an impact on performance of the team, of the surgical precision and accuracy, and in fact it does. And we asked some of the surgeons that are very much part of the faculty of NextMed to go and try that out in their ORs and to give a review, to give feedback.
Yeah.
And indeed, they were like, we can see where this is really going to work. So we're going to be playing with this more today, and
I'm excited
more
for
tonight.
that.
We'll be doing karaoke with it. So, but before we get to tonight,
what do we have in store for today?
Wow, we have a lot to get started with. So, the first thing that we're going to be launching with is Ron Balliser, who's coming to us from Israel, and also Michael Snyder, who's leads genomics at Stanford University. And so, when you think about these really big shifts in how we're using data, how we're using genomic data. We heard yesterday from the UK, from Baroness Nicola Blackwood and their CEO of Genomics England, Chris Wigley, learning more about how they're, remind me, million genomes or 100,000?
100,000 genomes. I mean, they're at 5 million, but it's called the 100K project.
It started out low, but they've got so many more. So we're now looking at how we're doing some of these programs in the US and the thought leaders who are leading that. And we're going to be spending time talking about neurology and the brain. We have Divya Chander and David Eagleman who are going to be talking about that. We're going to be talking about changes. I think we've learned a lot with COVID and the vaccine development, that within pharma and bringing the monoclonal antibodies to market, those were done so rapidly. And it's not all that rapid. When you have people aligned in the process, when you have partners who are thinking about how we share our information, how we share our research. We demonstrated that we can get things done pretty swiftly. So with that background, I think that a lot of people in pharma who are in drug development are looking at, okay, how do we use that model? And how do we use those alignments
to accelerate, sure,
to make things happen a lot faster? So David Faisenbaum is going to be speaking. So this is a physician who diagnosed
Flex.
not only his own orphan disease or rare disease of Castleman's, but then actually went and chased his cure. So an incredible story, an
really
incredible
powerful
book.
I mean, he was pretty much on his deathbed 5 times.
An incredible
and saved
human
himself.
being.
Yeah.
So he's really a trailblazer and really a maverick in some ways to say these things can be done without having to actually develop whole new drugs. There are things that are already in our formularies. There are compounds that we can use. How do we find and discover how to use them differently?
Sometimes I feel like the pace of our innovation is exceeding our ability to keep up, right? It's going so fast. I'm curious about some of the learnings that we even saw during COVID. Like, are there cautionary tales that we need to be aware of when we do accelerate or have the ability to accelerate innovation?
And we will be talking some about that when we talk about quote unquote digital health. We've talked about, is it really digital health, or is it it's all health or healthcare?
That's exactly, that's right.
But one of the things that we found so clearly is that as we accelerate, when there are disparities in care, digital and any of those things that have an exponential on them, we also accelerate the disparities. So that's one of the things that the entire lens is, as we are moving forward, how do we do so equitably? And
oftentimes we don't know what we don't know, right? And I think that for me personally, being here and just trying to listen to folks and understand where potential gaps are in our innovation developments are really interesting to me. So, figuring out how do we make sure that we don't make some of the mistakes that we've made over the past couple of years and advance innovation going forward. So I'm excited about it. And especially, I think we have longevity topics today too, right?
That's what I was just going to say.
Right.
So longevity, age, health span. Ken Dykewald is here with us.
Big topic, yes.
Ken Dykewald is going to be here with us today. And actually, recently, we hear about aging well, aging in, there's a lot of framing around that. But I have recently been introduced to Sarah, not recently introduced to her work, but Sarah Zanton's phrasing. She talks about aging in community. Because as we think about, one of the really key factors of our health is our connectedness and being in community. So Ken's going to be doing a lot of the discussion.
That's
and helping
interesting.
us.
Age in place. Like, why do we say place? Like, no, I want to age in movement, right?
And I want to be with people that that help me to be the best that I can be.
Right. Yeah.
People that I care about, people that care about me, pets. Yeah. So that whole aging in community, and Ken will really set the stage and give us a much broader view to understand the scale and the scope, like how many people. And when you look across the globe, the trends of where we are with our demographics and how many countries are looking at a much older population and a declining birth rate. So there are a lot of issues that we need to be mindful of when we look at that.
Yes.
So that's going to be.
And there's been a lot of seminal studies that have been published over the past couple of months. I'm really excited to sort of get into discussions around what does it mean as we compare our genome to the epigenome and the science that we've learned around how we can alter the epigenome as if it's kind of like a software code for our body.
Right. And we'll have some of that that's going to be presented by Nicole Bradford that's talking about transformative technologies. And I'm checking my notes because it is so
It's
packed.
A jam-packed day.
We're going to have, we're also going to be talking about surgery in the metaverse. So Shafi Ahmed, who has been such a pioneer in how we use technologies that allow for training to happen, to democratize the training of surgery. And
he was one of the first surgeons to have actually done like a virtual, a VR surgery across the world.
With the idea of we don't have enough surgeons in all the right places.
Yes, from an educational.
So how are we going to train them? It takes a long time to build out medical schools or any of those surgical residency training programs. So what does it look like if you can virtually join in? And actually, when Shafi first started that, what was interesting to me is that people who were thousands of miles away had a better view over the surgical field
than you're standing right next to him. That's right. Yeah, I can see that.
So, he always has great stuff up his sleeve.
And they're getting the direct view of his view into the patient, which is
your view of the
amazing.
surgical field does not get any better than behind, looking through Shafi's eyes. And then also we're going to have Brennan Spiegel. He has been really helping us to think about virtual reality in medicine and how it's a therapeutic.
Right.
So he's at Cedars-Sinai. He's running some really interesting programs that are training and developing an app library for how do we use the VR technologies in managing pain.
Pain, yes.
In thinking through how you're going to be preparing for a surgery.
Yes.
In thinking through how you're going to manage your post-operative care or your rehabilitative care. So again, he is really pushing it's not so much he's pushing limits, he's just opening up, here are these technologies, come and play, help us to develop a much broader library of how we would use these virtual technologies to improve all aspects of your care and your treatment, inpatient, outpatient, ambulatory, and again,
I mean, that alone, just VR for
pain.
pain. I mean, think of all the complications that arise from our anesthesia protocols that we do, around surgery and so forth. So being able to just address that is pretty amazing. And also, he's a human beatboxer, so maybe we'll try to convince him to do a little beatbox on stage before his talk.
So there's all sorts of stuff that happens on the stage that you'll be able to join us with. But I wanted to give you a list, just a little bit of the fun and color of all the things that happen off the stage. So then tonight, during the day, one of the things that's really fun is we have our iconic scrub shot. But this year what we decided to do is we're going to have you can print your scrubs. So they're going to be a choice of logos that people get to put on their scrubs. And then we're going to put the Highway to Heal NextMed World Tour schedule on the back of the scrubs. So there's fun and games like that.
Do we still get to take the iconic photo of all of us on the lawn? All right.
Yeah, weather permitting. It may be out there in the rain, but no, actually the sun is out, so it's warming up. And it is a beautiful day here in San Diego on Coronado Island at the beach.
When is it not? It's always beautiful here.
It is. It's made more beautiful because of the people that we have.
Yes.
And the spirit that they bring.
Yes.
So
to be able to hug again.
You know what? Last night at our sacred cacao ceremony, what I saw is people know how to do not social distancing. It was really it was really beautiful to have that ceremony where there is an intention set and a meditation around it.
Yeah.
And then really feeling your own heartbeat, your own breath rate, and just listening to this very mesmerizing, remind me of like whirling dervishes in some ways. That you just get into the rhythm of that, and your body starts to feel the vibrations, and the community that you create there, you start to collectively feel that vibration and that energy. It was
that
beautiful.
Sounds amazing, yes. And that was led by one of the speakers, Jamie Metzel, who ran the Sacred Cacao ceremony last night. So what's happening tonight?
Well, tonight we're going to be moving into more magic. So if you were watching us and you saw Robert Strong, that was so fun on stage yesterday, a form of Jeopardy for NextMed.
That was hilarious.
That is only Robert Strong, the magician, can pull off. So we'll be doing more magic, and we're going to have karaoke.
That's right.
So that's why I said everybody needs to get up to date on the lyrics. So there will be a lot of fun. So again, a lot of programming, a lot of really heavy content. We also get to go do our breakout sessions today. So people who were on the stage yesterday, they will be presenting 75 to 90 minute.
So how can our viewers get access to some of the conversations in the workshops?
They have to
So you
come.
got to come, or we'll see if maybe track on Twitter.
Yeah, plenty of people are tweeting about it.
Yes.
One of the things that we really love is when people create their own blog posts. They will write about the experience that they had at NextMed, and then they post it on LinkedIn. And what's interesting is seeing how other people perceive
their
and
interpretation
experience.
of it, yes.
Well, what they took out of it. It's not even the interpretation. How they're going to be using these ideas in either their practice, their workplace, in their development of new products and new collaborations. So it is amazing when you plant these seeds to see where they grow. And we have a decades of history where people come and meet here they hear an idea, they meet somebody who's leading.
Well, if I had a dime for every time I heard somebody say, well, that topic or the person I met over at Exponential Medicine and so forth, I mean, there's so much ongoing collaboration that happens out of here, or seeds of ideas that come from here.
We should have one of the folks try to track that to see where the seeds grow.
Yeah.
But anecdotally, we can say it's been significant.
It really has.
It's been significant.
Yeah.
So anyway, we have a lot going on the stage today, more happening in the innovation lab, and a lot happening in the evening. And a lot of it is really just these people, the humans connecting, but they're connecting over ideas. So we invite people to not only listen to the ideas, but to absorb them and connect over them. And our virtual audience, our remote audience, we invite you to do the same thing. We would love to hear, when you're hearing these ideas up on stage, how are you using them in your environments? What questions do you have? So please make sure and tweet at us. We've got a great digital swarm that's responding to a lot of them.
Yeah, that's great. So it looks like everyone's starting to gear up for the program that's going to kick off at 8:30.
We are getting ready to go live onto the stage. And actually, I think we're pretty close to. What are the other things that you wanted to chat about? Do you have any?
I mean, for me, what I'm most excited about today was just, I mean, some of the topics are really fast. Longevity science to me is really an area of personal interest. But really just the buzz around here. I mean, some conversations that I'm having with folks in the hallways, over drinks last night, over dinner. Absolutely
over
amazing.
Chocolate.
That's over chocolate. You know, those are my favorite parts. And so I definitely encourage you, if you've never been out here, to come to NextMed in person, because it's definitely a different experience. But I also understand if you can't make it all the way across to where we are. But
yeah, we want to make sure that we're as accessible as we possibly be.
Yeah.
That's again one of the planning. When we think about the programming, we have a lens on equity and accessibility. And so that's part of why you and I are doing this, why our partners in all of this really make sure that the content that we have, we make it as accessible as possible.
Yeah.
So I'm having fun. Are you?
Yeah. I'm having a blast. I mean, I cornered Dave Albert this morning, who's the founder of AliveCore.
Who will be up on the stage today.
That's right. Yeah. And we were just having this incredible conversation, even just talking about what is innovation. And we all have different definitions of what innovation is, right? He's like, well, it's something that we're just doing different. I'm like, okay, well, if we unpack that a little bit, can innovation be bad as well? And
that would be okay. So put this out. #NextMedHelp. Your definition of innovation.
Oh, I would love that. Yes. Give us your definition of innovation.
And it's amazing when you ask people, how do you define innovation? I am overwhelmed by the range. I will ask you later. I have mine, but I will ask you later. But we're not going to precede.
Yeah.
We're looking for your definition of innovation. So innovation is #NextMedHelp.
I will put mine on Twitter as well. So I'll refrain from you know what else?
And then we'll share some tomorrow.
What is your definition of health? I would like to know that as well, right? Because oftentimes we define it as something negative. It might,
the absence of.
When we think, you're right, the absence of disease. I'm curious, how would you define health? So health and innovation. Give us your definitions. I'm curious.
Sounds good. All right. So we are about ready to go live on the stage.
Yep. We're getting the cue. We're getting the cue.
Yeah. I think that they're probably ready to go live to the stage. Yeah. So what are the other calls to action before they cut us off?
So again, use the hashtag NextMedHealth. Let's say NextMedHealth. NextMedHealth. At NextMedHealth is the Twitter handle.
The live stream is
the live stream is nextmed.health/live. Does it have to be lowercase L? I heard Daniel say it, but
lowercase. But
I don't think that really matters, right?
Yeah.
But either way, /live. Those are the best places to go. That's where most of the conversations are happening. Again, if you want to write about it, tell us about it, notify us, tweet about it, so we can actually retweet it and share it with others as well. And if you have questions, share them with us.
Yeah, we would love to hear those.
Yeah.
And I'm trying to think if we had any other surprises planned for today. Oh, we do. You do not want to miss the middle of the day. We have Aloe Black coming to perform
he's amazing.
Incredible live sets for us today. How can I forget? I know why I forgot, because there's a certain surprise element. So I've been told, don't say much. But we can say it now.
We can tell you. So you guys are in the know. I mean, he is just a beautiful human being.
Yeah.
Incredible musician and performer.
So
if you've never seen him.
He'll be live on stage performing today, and actually...
And if you don't recognize the name, you'll probably recognize the songs.
You'll know the
for
music.
sure, as soon as you hear it.
Yeah, so yeah, he's going to be performing, and we're going to tie in this understanding of how does music change your brain, your body, your behaviors, and we have some demonstrations on how we're going to be sharing that. So yes, please make sure that you follow along with that. And I think, there's so much going on. I would like to say, I think I've
This
covered
is going to be a jam-packed day.
Plenty of things that I've missed.
Right. Well, we felt like it was a jam-packed day yesterday. It was a half day.
It was a half day.
But true to how Sean and Daniel curate a program, today is going to be a jam-packed day full of content, full of information. You're going to have a nice gap in the middle when the workshops are happening, but we'll try to get on Twitter and be active and share across what we're seeing and hearing on the grounds here. So definitely stay engaged.
have the future. We have the future music. Welcome, everybody. You have a good first day? That was only like the first 10% of the program, so hopefully your brains aren't full. Who met some really amazing new people last night or yesterday? How many folks were at the magic cacao ceremony? All right. How many folks got turned into a avatar so far? Anybody get to try that? So your job over the next 2 days is to go visit the Blue Vishnu section, and you can all be turned into your own personal 3D avatar to bring into your own personal metaverse or mediverse space going forward. So that's a great opportunity to digitize yourself as an experiment. Here were some great some photos I took of the magical cacao ceremony led by Jamie Metzel. Where's Jamie? Thank you, Jamie. That was amazing. So definitely not your average start to a health and medical conference. And some of you might have met my amazing parents. They're on the right, so I don't know if you might meet my parents here. Thanks, Mom and Dad, for getting me here. I think my wife and kids will show up tomorrow. We're going to an amazing day two. It's going to be full on. We had some fundamentals yesterday: AI, genomics, synthetic biology, systems thinking, and more. And now we're going to sort of see some concrete examples of how that is integrating into the world, and really what's cutting edge and what's already here, and what really some of the implications are for the future. And I'm really excited to have back my friend, an amazing individual, a real leader in healthcare that's impacted all of our lives, Dr. Ron Balaser, who is coming from Israel all the way, a little jet-lagged. He's the Chief Innovation Officer and now also the Assistant CEO for Clalit Health Services, the largest healthcare system in Israel and one of the largest integrated health systems in the world. And a lot of their work, as you'll learn, really was fundamental in the pandemic to learning which vaccines worked, and some of the public safety and other elements really fundamental and impacted all of our lives. We've had a chance, I was in Tel Aviv with him at his Clalit Innovation Center last December, hung out with other cross collaborators like Zach Kahani, and a real amazing individual, as you'll see. So really pleased to bring back to our faculty Professor Ron Balaser.
It is such a joy to be back here on the stage of NextMed after these very challenging few years tackling COVID. So it's really a huge joy spending time with such scholars. So what I would like to try to cover today is the minor issue of prediction in healthcare and where this is leading us. So I'm going to take a bold prediction here, and bear with me. I know that prediction is hard, especially about the future. It's been attributed wrongly to many people, but it is true. I will predict that 2023 is going to be, for most health organizations out there, worse than 2022, and that 2024 is going to be worse for most health organizations than 2023. And why is that the case? That is the case because we have a serious problem of sustainability. It's because we have had some challenges that have been mounting over the time, with the population aging, with multimorbidity, with the rising cost of technology, with the rising demands of EHR documentation that are really making it difficult for our frontline workers, with patient expectations continually rising, and all of this increase in demand is met by a relatively diminishing workforce. Now, that doesn't work well on the long term. And the problem is becoming more and more acute. And the people who stand in the front lines are the ones who are now bearing the consequence. So the problem of burnout shouldn't be a surprise, but this is making it worse for everyone who's staying in their jobs. And this is quite a serious challenge. Now, this is a problem of sustainability. It's a cliff's edge, and we're going there very, very quickly. Our industry is not sustainable, and the only way to change it is not to try to pour more money into the system or to try to somehow train enough healthcare professionals to meet the increasing demand. That will not work. What we really need to do is transform. Imagine for just 1 minute that you've had a gift, that you could look at someone and know that something bad is going to happen to them. Not only that, that you could see an alternative route for them that would take them out of harm's way. Life would be amazing, wouldn't it, if you had that gift? It would change everything, the way that you do a lot of things. It will also change probably how we practice healthcare. Now, this has been alluded to yesterday by several of the speakers. Imagine that instead of coming to your physician with your ailments, with your pain, with your discomfort, with your disutility, they would call you and tell you either that you will have within 12 hours a cardiac arrest, or within a year, acute renal failure. This would be really impactful if this could be the case. Now, this is not a theoretical construct. The technology is here. Some of you who are aware, for instance, of renal failure know that by the time that this very debilitating condition is already manifested in clinical symptoms, it is too late to make a difference. If you want to make a difference in end-stage renal disease, you need to come early, when the patient looks well and feels well, but is on the way downwards. We cannot, as clinicians in most cases, identify that point in time, but computers can. And they don't need sophisticated omics-driven data to do that. They just need what's out there in your clinical records today. How do I know? Because we created such a model 13 years ago and implemented it on the masses. So the technology is there. If you'll think about it for a second, it only makes sense. None of you treats their car like we treat our patients. Imagine that what you would do with your car is you drive and drive and drive and drive until you have smoke coming out of your engine. When you see smoke, that's when you go to the shop and try to get it fixed. Nobody would run healthcare, would run a car shop like that, but we run healthcare in a reactive manner that is similar to that, and that doesn't make sense. So the technology is here, waiting. The need is urgent, but still, this amazing future that awaits us all is at our fingertips, but in fact, it is not. And when we walk around in healthcare systems around this country, my country, and every other country, this is not what we see in the daily practice. Why? Why is it not the case? There's been a lot of disillusionment from AI. I'm fully aware of that. Some examples were given yesterday. Watson was one, others. But I think that this disillusionment and this worry that maybe the promise is not real has been premature and wrong. The promise is very real, and it can be realized. The problem, I think, is not even the problem of conservatism. We all work in a very conservative system that is very hesitant to change for good reasons and some that are not as good. But this is not the reason. The reason, the way I see it, is different. The problem is incentives. The systems are not incentivized to change that way. And when you have a strong enough disincentive in front of an executive, this will not change. Yesterday, I think it was Lee Hood that said in the evening, wouldn't it be great to see a future when prevention will be as profitable as care? Well, like in many other instances, the future is here, it's just not evenly distributed. What would a system that would allow this to happen, what would it look like? I would offer the following potential needs. I would say that you would need a system that's big enough to have a critical mass of patients to take care of. That you'd like to have a universal inclusion, so you wouldn't have cream skimming of only those who are most profitable. That you would have in that system a lifelong outlook, so you would need the patient to remain healthy because you are responsible for him or her 5 years from now, 10 years from now, 30 years from now. So it makes sense to invest now in their future. That you would be integrated by design, that you could bridge the silos of primary care, specialty care, and hospital care. That you have enough data, and you don't need a lot. You don't need all the data in the world to make this happen. You can actually do this with very little data. And finally, that you will be willing to innovate. Is there a system like that? Enters Clalit, which is Israel's largest healthcare organization that cares for over half of the population, 5 million people, from cradle to grave. It gets its money through capitation, and it gets the same amount of money whether you're sick or you're healthy, so you might as well keep your patients healthy. It makes sense. You have only 1% annual attrition. People can move, but they just select not to. And there are 3 other organizations that are competing. It is primary care focused rather than hospital beds and filling those hospital beds, and it's been digitized since the 90s. So we now have at our hands about 5 million lives with 25 years of digital data on those patients cradle to grave. Sounds appropriate for the task? Data is not enough, okay? The issue is not the amount of data you have, but what you select to do with it. So what can we do with such data? This is something we've done about 15 years ago. No need for, advanced AI solutions. We found out differences, in this case, in anemia at the age of 1 year between subgroups within the Israeli population. We identified the disparity. We created an intervention program based on this disparity, and we closed the gap completely, annihilated that unequitable situation. So this is what you can do with data and zero technology. But if you have the data and the technology, you can do things like what I've presented before. You can predict which one of our patients is going to be in 5 years from now in end-stage renal disease, because we can do the predictive models, because we have data that goes 5 years back. So we can go 5 years, look prospectively in hindsight, and then say who will deteriorate. That's pretty easy. But it is not a technical thing. It's a paradigm shift from patient level, reactive therapeutics, to population health, predictive, proactive, and preventive in nature. There are many examples. I will give a few today just to explain that this is not a theory. This is implemented at scale on a national level within Clalit. We started doing this in 2015. We have to call every winter and tell our populations, the elder population, to come in for flu shots. But we don't have enough staff to call all of them, so we call only a few. How do you select them? Alphabetical order. So if you have your last name begin with a Z, that's tough for you. Instead of doing that, what we did was to predict who is the most likely to have winter severe morbidity, and then sort the list based on this. So you'd call first who needs it most. This requires the advanced technology of the sort button in your Excel sheet. I'm sure you can all do that. Nowadays, of course, we do this in more elaborate ways, and we add more and more types of data into the mix. Everything that can fit and can be analyzed with more advanced technologies that are from the deep learning domain come to the mix. And again, we will have more and more of that coming in, but this is icing on the cake. This is not a requisite to make this tick. All you need is your EMR data, basically. So when you take this type of data, and you push it into the system, it can, for instance, identify that in your CT that you've done for abdominal pain, there's actually something in your vertebra that suggests that you are most likely to break your bones. I cannot, and the best imaging experienced physician cannot look at the bones and say that, but the computer can. Now, we know that because we've been able to demonstrate it and to show that it actually, this single CT scan can give you information that is equal to all of the clinical information that you can get from the patients in the current state-of-the-art tools that are used for this, in this case, the FRAX. And we compared 3 different systems, and still, CT was better than any and all of them. So this kind of sometimes you want to ask the black box, does it make sense? Is it doing the right decisions? I'll give you one example. When we tried to predict osteoporotic fractures, one of the first things the computer spit at us at the end of the day was, this is strongly associated with eye disease. I went to med school. It was a while ago, I agree. But, I've never learned anything about a pathological process that is joined to the eyes and the bones. Not collagen formation, nothing. Why does this happen? Is it a computer glitch? Is it a target leak? What is this? Any guesses? Yeah, if you don't see, you fall. If you fall, you break. It's not that it causes osteoporosis, it's just manifests your osteoporosis in a fracture. So, computer 1, human 0 at this point. But it's okay. Not always we understand how this works, but it works. So, you saw before that it was mentioned that we did not do well in COVID in terms of AI. That is actually, again, not true. AI did not fail everywhere to live up to its potential. This is just one example. As early as March 2020, before we had only a few cases in Israel, we already created an anticipated predictive model for severity of illness of COVID-19 patients. And we called individual phone calls for 200,000 highest risk population of Clalit, each and every one of them. We tracked it. I know. It's 99% that got the call. And we told them there's a new disease. It's called COVID something. Stay home. And the impact on eventual morbidity during that first wave was just amazing. So this can work. We then improved the model with data. First of all, we created I'm sorry for the Hebrew, but we created a simplified model with points, that you get a specific number of points for any illness. You collect the points together, and you know if you're at high risk or not. So if you're at high risk, you can do this at the comfort of your home or in every physician's office, and it worked really well. We could put it on TV. I was, at that time, the chair of the National Advisory Team on COVID-19, so my days and nights were pretty hectic, but we used it well, and on national TV, you could tell the patients how to do their own calculation and know if they're at risk and act accordingly. So it's prediction all the way to the patient. So, by the way, it worked, and we know because we have assessed it, and we have had really nice ROC curves eventually to show that this works. Later on, we improved the models and used them to decide who gets Paxlovid, the treatment to reduce the risk of severe COVID-19. So this was, again, something that worked very well. I will only mention that we used AI in different ways during COVID. Here's another example. In the second wave, we had paucity of tests. We didn't have enough. So we created a predictive model. By now, you'd guess. A predictive model that says, who's the patient who's going to get infected tomorrow? Based on what happens to his friends, his family, the place he lives, his personal traits. It worked really well. We had pretty good outcomes of that model, and the way it worked is that when a patient went into the physician's office and said, I have stomach aches today or back pain, the physician said, yeah, that's okay, but my computer says this is an alert that actually appeared on every one of our screens for several months with such patients. Maybe I want to ask you a few other questions like, do you have a loss of sense of smell and taste? This was in real time, and it made a difference. So AI did work during COVID-19. Finally, this was the toughest decision that we had to make based on AI during COVID-19. So we were vaccinating for about a month. It is January 2021. And we had lockdown for over a month. And despite all of this, numbers of severe cases kept mounting higher and higher. So you need to make a decision. Do you open the lockdown? Or do you trust the vaccines and open the lockdown, or are you careful and you wait until you see something different? Now, the reason we knew we had to be careful was we saw a similar picture in the second wave, and what happened afterwards was a huge rise in cases. So when you stop your lockdowns, you could have a rebound, a serious rebound, and one would expect that. So if that would happen now, and we take the wrong decision, we were at capacity. We couldn't add one more patient to an ICU bed. We know from other countries what happened at this point if you make the wrong decision. This is an ICU bed when they didn't have time to take the deceased out of the room because the turnover was too big. For some of us who forgot where we were just a couple of years ago. So we didn't want to get there, okay? This was high risk prediction. So what did we do? We used the methodology that, again, we use again and again in our work, which is creating digital twins. We try to create identical twins that look just one like the other, only different in terms of their vaccination status. So if I have a 74-year-old male, ultra-Orthodox Jewish, that lives in a neighborhood in Tel Aviv with 3 chronic conditions and 4 recent hospitalizations, I couple him at the same day with a 74-year-old male from the same neighborhood in Tel Aviv, again, ultra-Orthodox, with 3 chronic conditions and 4 recent hospitalizations, but that was not vaccinated. So these are my twins. And now I follow them until the unvaccinated gets vaccinated, in which I decouple them, put another, in this case, unvaccinated twin to that point in time, and this is an approach that is called emulating the target trial. It's a way of making causal inference from retrospective data without making serious biases. So to cut the long story short, we had the first in the world assessment of vaccine effectiveness, and it showed us very clearly vaccines work. So we saw that in real time. I want to and acknowledge here all of the people that were involved in this, both from Talit and from our wonderful colleagues at Harvard Medical School. And we made a decision, open the lockdown. What do you think happened? Numbers went down, thank God. But this was a leap of faith. And I got to tell you, your ability to do prediction on a daily basis helps you during emergencies as well. So we've done it a couple more times, actually double-digit number of times since then, working on different aspects of tackling COVID-19, seeing whether vaccines work, what are the adverse effects of vaccine in the real world, how do they move from within families, are the drugs effective or not. So this actually is very helpful in making decisions on your daily basis. And this is from a couple of months ago in a celebration with, this is the President of Israel in this case, of this collaboration that we have with Harvard Medical School on doing this on a massive basis and on sharing learnings and co-designing interventions. So this becomes embedded in clinical practice, and we do this for a lot of different conditions, okay? And if you want to know outcomes, here's one. We try to intervene in multimorbid elderly patients, and we identify those at the highest risk of deteriorating. You have here the control group and the intervention group. And then, what happens to the control group? Of course, numbers go high. That was predicted. But among those that we intervened with a nurse and a physician working together to prevent further deterioration, there's actually a decline, and we were able to reduce admissions by 43%. The cost averted in this was more than the cost of the nurses that were involved in this process. This is cost saving. This is the triple win that we were looking for. So what we have been trying to create is what we call a learning healthcare system. Not in theory, not in nice slides, but in the daily work. We define the need, we develop the solutions, we test them in silico. We get a sign-off from the clinicians that it works. We deploy in the clinical settings, and then we evaluate the real-life impact, as I've just shown you. And I'll show you just one more example, and it'll be actually very brief about it. HCV, we now have amazingly effective treatments, 97% effective in doing this. We want to eliminate HCV, but for this we need screening because we know that 50% of those infected are undiagnosed. So we go ahead, and this is the PI over there, Noah Dagan, and we go ahead and we screen the entire population. We identify those at the highest risk with really cool models that identify them, and then we go ahead and proactively approach them. After we approach them, we see that as compared to the normal screening processes that we run, we get a 100-fold number needed to screen lower in this approach than the usual approach. So imagine that you can screen 100 times fewer people and get the same number of those who require treatment. Wouldn't that be amazing? So, what's next? We've outreached those patients using emails and text messages. That's cool, but it doesn't work because physicians are weary and tired, and they do not want an influx of insights that you're going to drop on them in the middle of their 5-minute encounter with a patient. Thank you, but no thank you. Even right now, there's not enough hours in the day for them to do whatever the recommendations are for them to be doing. So is there an alternative? What we've been trying to do in the last 4 years is create an innovative platform that puts all the relevant data for the patient, for decision-making in real time, puts everything together, mix it all together, and goes all the way for the bottom line. A single screen with a crisp bottom line of what they need to get done. So you get both the AI prediction of identifying who is at the highest risk, and you also get the personalized recommendation and care gaps. It's called CPI. And what it does is that every night, all of our patients go through this medical sieve, in this case, and recommendations are made for each and every person that goes all the way to the physician in an explainable AI form they can hover over. And surprisingly enough, the physicians, instead of yelling at us, they're happy. So there is a way. Won a few prizes, doesn't matter. So what's coming next? And with this, I'll adjourn. We will be talking a lot about omics. And indeed, we are now in a process of whole genome sequencing 500,000 patients within Clalit, trying to transform care to, first of all, better, more precision medicine appropriately in order to provide the right care to the right patient the first time. So this is classic for what we think about omics. We think about precision medicine. But what I'm trying to tell you, that this is actually something that can help us with something very different. This can help us with predictive medicine. The actionable genes that already are recognized can be used to prevent future illness. The polygenic risk scores that we can create today can come and augment all of the other inferences that come from every other modality and improve our predictions. So we can use omics not just for precision medicine, but also for predictive medicine. So think about that. Future is bright. I would want to finish up with this following slide that reminds us that innovation is not about technology. The technology that won the highest prize for innovation in Israel last year was the one in which a cardboard was put in the patients at the geriatric hospitals near their beds. And that cardboard had pictures of that patient, not what he looks today, what he looked when he was young. When he was young and a boxer, when she was young and she was a dancer. And you have that, and when the family comes in, instead of looking at the patient at the bed and how they look like today, she actually looked at who they're actually treating. This reduces burnout. This increases the engagement on the family. This is innovation. So innovation is not just about technology. Like medicine, it's all about the human touch. Thank you.
Fantastic. First of all, a huge debt of gratitude to Ron and his team for all they did through the pandemic. That was really impactful. Amazing work. And I think you met Leroy Hood yesterday, precision, personalized, proactive, P4Meta. You building that in reality, and you come from Startup Nation. You have this amazing Cloud Elite platform, and you're now working with Harvard and others. What are the kind of abilities to take the now, near, next, what you guys are doing already and showing impact, and the kind of catalyzing that in other systems? In the US, there's thousands of systems, many of them misaligned with incentives.
So I think the first point to make is that you don't need a whole lot of data in order to make this happen. It's really difficult to create the models in the first place, but once you know and identify the biologically important factors that need to weigh in, usually with 5, 10 factors, you can get 80% of the impact. So you can do this in all of your healthcare system, no matter how primitive some of the data collection and aggregation systems are. So you just need to have the right impetus and the kind of a sustainable approach to making this happen on an ongoing scale. And then it can be taken everywhere, and those who are interested to get more insights from what is actually working, please don't hesitate to approach, and I'll be happy to share.
So you'll eventually be able to have like clay in a box that can be imported into other systems?
I think so. The CPI system, the Clade Preventive Proactive Interventions, I think right now we are too busy deploying it and increasing the number of chronic diseases and acute diseases in that. But once we're in a good shape, there's definitely something that will go ahead and be offered globally for every health system to try to implement.
Thanks so much for creating the future. We'll see you a bit later today. Thanks.
Thank you so much.
Legend. Another legend. This is an amazing session. Really honored to have from Stanford, the chair of genetics, also the director of the Stanford Health Innovation Lab, who's done, I think I showed a slide almost in every one of my keynotes about the check engine light for the body. He's probably the most quantified individual on the planet, as you'll hear, and driving what starts with an N of 1 to the N of thousands and millions. And we're going to hear from Professor Michael Snyder. Mike.
Okay, it's a real pleasure to be here. I think you've been hearing already how the healthcare system is broken. It's really sick care versus healthcare. But even when you try and practice healthcare today, I would argue it's still very antiquated. If you think about it, you get in a car typically to go to a physician. You wind up at a doctor's office that looks pretty much the same as it did 40 years ago. Maybe a few gizmos are updated. They'll take a very large aliquot of blood from you and a few other measurements, and they usually use a needle that hurts. From that blood, they typically take very few measurements. And then from those measurements, they'll make some decisions on you based on population-based averages. We think virtually all of these steps are broken. Okay, and with regard to the last one, it turns out, you've probably been told since you're little, your oral temperature when you put a thermometer in your mouth is 98.6. But if you look at the data that's out there, it's more like 97.5. I myself am 97.3. I've been dropping over the last 8 years. But the more important point up there, there's a spread. The bottom of that box is a 25th quartile, 94.6. The top of the box is a 75th quartile, 99.1. And what that means in today's world, if your baseline is normally 94.6, you walk into a physician's office, they measure you at 98.6, or they'll tell you you're normal, everything's healthy. What are you doing here? Go home. But I guarantee if you're up 4 degrees over your baseline, you're not healthy, something's off. And so our shtick is we think you really need to know what your baseline is for lots of different measurements, and then try and detect shifts from that. So we're in a world now, you've been hearing already, where there's new technologies that can measure you at a level that's never been possible before. Pretty soon we'll be able to sequence a genome for $100. It'll cost more to interpret it, but it will cost about $100 probably by the end of the year to sequence a genome. We can make literally thousands of measurements from your blood and from your urine using mass spectrometers and other kinds of technologies. And then the wearable technologies are taking over quite a bit. And just out of curiosity, how many of you are wearing a smartwatch or a ring? Oh yeah, this is the right crowd. Great, all right. So we're going to talk about all that today. Okay, so a number of years ago, I think Dan alluded to this, we set up a project called Personal Omics Profiling. We started with me, it was 13 years ago. And the idea is to collect very, very deep data on people. We would sequence their genome, and then we would do these other omics measurements, which really measures many molecules. You've been hearing about them already, out of people's blood and urine, so we'll follow their RNA, their proteins, their metabolites, their lipids, their microbiome. We do this on top of deep clinical tests and questionnaires that we run. We started with the wearables quite some time ago as well. We'll spend time on that, as they say. And then this is on top of some advanced tests, stress echocardiograms, and various glucose control measurements. And we would collect very, very deep data on people, literally 1 billion measurements or more, and then we would do it longitudinally. So we would sample people every 3 months while they're healthy. If an adverse event like a viral infection came along, we'll typically take 5 to 7 additional samplings. So we're doing this to try and understand what health looks like, not what illness looks like. That's important too, but we want to understand what a healthy baseline looks like. How does it change over time? How does it differ between people? What's the difference between you and the person sitting next to you? What happens at the earliest time of illness? And also, can these advanced technologies like genome sequences, omics, wearables be useful for better managing people's health? And with regard to this last point, just from the first 3.5 years, we started this on a study of 109 people who were older, say 53.4 median. It's quite a spread. And from those first 109 people, we had 49 major health discoveries spanning a wide range of areas like heme-oncology, cardiovascular disease, metabolic disease. And it turns out this was all found pre-symptomatically, and some of them were a pretty big deal. We found early lymphoma. Just beneath that under heme-oncology, you'll see 2 precancers, MGUS, smoldering myeloma, that can convert to aggressive cancers. Cardiovascular disease, 2 people had very, very serious issues going on, had no idea. Again, all found pre-symptomatically. And the other point up there is no one technology did this. Sometimes it was a genome sequencing predict risk, like one of the cardiovascular disease case. Young person actually had a mutation in that RBM20 gene, which puts him at very high risk. Turns out follow-up tests, he had a stress echocardiogram, and sure enough, he actually has a heart defect. He's on medication now. So all these things, again, were powerful. Sometimes it was imaging. Sometimes it was some of the blood markers. Usually it's a combination of measurements that said something was off, and then follow-up tests actually found this. And so the way we like to think about this, if your health is a 1,000-piece jigsaw puzzle, the way we make measurements today, we measure about 6 or 7 of those and try and guess the picture. We're trying to take more like 600 or 700 pieces and get a much better assessment of the picture of your health. Now, the other thing we've learned is that by profiling people over time, we can actually see how they're aging. And it turns out everybody's aging differently. I'm the one on the left. I'm a pretty typical ager. My coagulation pathways, metabolic pathways, various things go up over time. Not so much my immune pathway. Happy about that. But the person on the right, their top pathway that goes up is their hypertrophic cardiomyopathy signaling pathway. So they're a cardiac ager, and we later learn they're stage 2 hypertensive. So that sort of makes sense. As we look through the various people, we see there's many ageotypes, as we call them. These are aging patterns. Some people are kidney agers, others liver, some metabolic, some immune, some all of the above. And so different people have different combinations. Some, as I say, have all these characteristics. Some are just kidney and so on. And there are clinical markers associated with these ageotypes, if you will, so you can actually take action on this, we think, and potentially slow the course and possibly reverse it in some cases. One question I get asked a lot is, how are you going to scale this? This is a research project, that's true. And so I'm in Silicon Valley. The way you scale it is you form a company. So we formed this company, QBio, which basically does a medical version of what I just showed you, but it also adds on whole body MRI, which in today's world, every physician will tell you, don't do a whole body MRI. Mike Snyder will tell you, you should do a whole body MRI. And the difference is, they'll say don't do a whole body MRI because you will have nodules. Women have them in their ovaries, men in their prostate. And that's not the point. The point is, do you have any growing nodules? And you're only going to see that through these longitudinal profiles. And I have 9 nodules, one on my brain, one on my spine, one in various places. And none of them are growing, I'm happy to say, but at least I know that. So if ever I do need a whole body MRI, I won't freak out when I see those 9 nodules, unless, of course, one of them's growing, then I'll probably have to worry about it. But until then, I'm pretty happy with that. Okay. The other thing we've been trying to do is actually this idea of doing remote sampling and remote measurements. And so we've been pushing very hard on this over the years with using wearable technologies and something called microsampling. I know what that's going to sound like. This one works. On the wearables, you may know there's hundreds of devices out there. A lot of you are wearing them, smartwatches, rings, all kinds of devices. There's over 1,000 these days. And so we actually brought these on early on when they were mostly just fitness trackers to see if we could use them as health monitors. And one of the first things we learned is that you can detect infectious disease pre-symptomatically with a simple smartwatch. And we got into this because we figured out my Lyme disease. It showed up because my blood oxygen dropped abnormally low and my heart rate went abnormally high, my resting heart rate. So on a plane, actually, when I landed, they didn't come back to normal. They were off. And this was all pre-symptomatic. I actually went to a physician in Norway. I warned him it might be Lyme because of the timing of when I would think I was exposed. He drew blood, said, yep, your monocytes are up. You've got a bacterial infection. He wanted to give me penicillin. I said, no, I need doxycycline. Got a little tense there. He did give in, gave me my doxycycline, cleared it up. When I got back measured, sure enough, I was Lyme positive. And I'm well controlled. I had given a sample before I left, and it was negative, so I converted during that time. We went on to show that we could actually pick up respiratory viral infections just with a simple smartwatch, actually. And then, and that was all done retrospectively. Even asymptomatic cases where I had high, something called C-reactive protein, we could pick that up. And then, of course, COVID came along, and if you think how we're measuring COVID these days, we use a thermometer, which is a 300-year-old concept, temperature, and it doesn't work a lot of time for COVID, right, because you don't get a fever. But resting heart rate turns out to be way, way more sensitive. So when COVID erupted, we basically partnered with Fitbit, launched a study, got 5,300 people involved, and 32 of them actually were wearing a smartwatch at the time they had COVID infection. They had a diagnosis day and a symptom day. And the top one, that's our very first case on the left. Resting heart rate's up top. And if you look at day 48, that purple day, that's the diagnosis day. Day 47 is the symptom day. That person's resting heart rate jumped up 9.5 days prior to symptom. Very clear signal. Okay, so they were probably running around for 9.5 days spreading this because they didn't know it. They're pre-symptomatic. And then I'll show you in a minute, we have a real-time detection system. I want you all to sign up for a study, by the way. There it is, innovations.stanford.edu/wearables. So we follow your baseline and look for this jump up in signal. And the net result from this first retrospective study is that basically we could detect COVID a median of 4 days prior to symptom onset, 80% of the time. Okay, so we still miss it in 20%. We think it's hard to get stable baselines on certain people. We think more data will solve that. We've gone on to build this real-time detection system. Again, you can sign up now. It gives you red alerts if you have an abnormal signal over your baseline. And basically, this is one of the first cases here. That's an individual who's getting he got 3 alerts, he or she, prior to symptom onset, which is at day 21 there. They were diagnosed the next day. And it works on Apple, it works on Fitbit, we think it'll work on all devices, and it even works in asymptomatic cases, same number, 80% of the time. And so we're actually trying to collect additional data types. It's mostly built around resting heart rate, has a little bit of sleeps and step data, and as we pull in other data types, we know we can get the sensitivity up. I do want to make it clear, it's not specific for COVID, it's a general stress alert. And workplace stress turns out to be the #1 trigger of red alerts. Intense exercise, excessive alcohol will trigger these as well. Most of this you can contextualize, and we think with more data we'll be able to tell the difference between a workplace stress and a COVID infection, for example. I don't know if we'll ever tell the difference between, say, COVID and an influenza infection. We'll have to find out. But it does pick up other infections as well, which we think is useful. We can also detect long COVID because people have elevated basically heart rate and other measurements as well. And so we're actually trying to see if we can subclassify COVID. And this will lead to my next part, which is, well, actually in a minute. The other kind of monitoring we're doing is continuous glucose monitoring. You may know that we're all very different in how we respond to glucose. What we did was we actually started putting these on people who are thought to be normal, healthy people. And what we discovered is a lot of people are spikers who didn't know it, meaning they eat something that spikes them very, very high. So if you look at the middle there, some people do have pretty good glucose control. Some are moderate spikers and some are severe spikers. And we've classified them algorithmically into glucotypes with these basic phenotypes. And we went on to show, as at Aaron Siegel, that different people spike to different foods. So some people spike to bananas, others to pasta, some to white bread, others to brown bread. We're all different. And it's due in part to our microbiome, but that's only part of it. There's other factors as well. This is some work from Aaron Siegel's lab. That top participant spikes to banana, but not to a cookie. Probably the only person on the planet that doesn't spike to a cookie. The one on the bottom is more normal, spikes to a cookie, but doesn't spike to the banana. That's a little more typical. But I guarantee a lot of you are spikers who don't know it. And we think these devices are very, very powerful for monitoring that. The other thing we spent 6 years working on is this microsampling. The idea of taking a little prick of blood, mailing it in by, say, FedEx, processing the lab, and then measuring thousands a day. That sounds pretty familiar to some of you. This one does work. We spent a lot of time finding devices that will collect analytes and keep them stable. We settled on these Mitra devices from the Aterix. We use these other devices called Tasso. And the person who helped set this up is Ryan Kellogg, who's here at the meeting. I'll show you in a minute. He's founded a company called Rhythm that's actually using this kind of technology. And basically, as I say, we can measure using omics technologies over 2,000 analytes, lipids, metabolites, proteins, and we have targeted assays to go after some very key molecules that are important for your health. So we can follow all kinds of things. As I say, we spent a lot of time measuring stability and knowing which ones are stable, which ones aren't. And then we went on to run 2 pretty fun studies. This was the first one. We had 32 people drink this shake that you can buy in a CVS. Doesn't taste very good. It's called Ensure. But we had people drink this, sample them, then drink it, and then measure them at 4 time points after. Saw hundreds of molecules that changed, including some pretty important ones. There's glucose control monitor measurements we can make with this technology, and also some other very important inflammatory markers we can measure. One of the coolest things we discovered with this is that everybody has a different response, even to the same simple shake. So this is just looking at 3 carbohydrates. The class of molecules all tends to behave the same. If you look over there, it's about the 6th one over. Each box is a different person. I think it's labeled S13. That individual's carbohydrates plummet after they drink the shake. But then just look 3 over, S21 it looks like. That person's carbohydrates skyrocket. Some people up, some down. Just look across. Everybody's different. Same is true if we were to look at free fatty acids, amino acids. And the coolest results down at the bottom, those little gray dots are the average of everyone. But if you look at that brown marker there, too bad we don't have a pointer here, but look at the brown marker. We had 5 classes of people. In group 5, the last one over, the brown marker is very low. That's inflammation. That person goes down, has an anti-inflammatory effect when they drink that shake. Go over to group 1 or group 4, the inflammation goes up when they drink the shake. Same shake. Some people are pro-inflammatory, some are anti-inflammatory. We think this is a big deal because 10% of people have inflammatory bowel syndrome and presumably react to different foods, and we can measure exactly what's going on when you drink what. So we think this technology is going to be very, very powerful for following individualized responses, not just to health, but to nutrition and lifestyle. And so we put this in action by taking one person, happens to be me, measuring them very, very densely every waking hour for basically 7 days, total 98 samples over 7 days. And I was wearing wearables and a continuous glucose monitor, so we could actually follow physiology along with all kinds of glucose measurements, and then do the microsampling to see all the biochemical changes as well. And there are hundreds of molecules that change over this time. That's not a surprise. But what we can do is we can start making correlations of which molecules correlate with what other molecules, as well as which molecules correlate with which kinds of lifestyle and physiological signals. And so the simple thing I'll tell you is, as you know, you can correlate activity with steps with heart rate, and we can show quantitatively there's a 1-minute lag. That's, again, a proof of principle. And we set up algorithms for being able to do this systematically, and we can follow hundreds and hundreds of associations between molecules with other molecules and with physiology and so on. And I won't have time to show you this, but it's very cool. You can match your lifestyle with its biochemical effects, so sleep and other things, and cortisol, all these kinds of molecules. The fun one I'll show at the top in that bottom part where it says alpha-synuclein, that's a molecule involved in Parkinson's. And we can actually follow it. It's bouncing up and down, and it does actually correlate with other biochemical markers and activity, potential stressors, and we can actually measure that. Now, I'm not at risk for Parkinson's, so it may not be, I hope it's not a big deal for me, but for other people, this could be a big deal and would be a very nice thing to be measuring so that you might try and reduce those spikes. This is the idea. It also turns out that that particular molecule correlates with glucose levels, which is kind of interesting. And we can also quantify, once again, glucose with various signaling molecules. C-peptide is an insulin-related one, which we can measure as well. So what we've done now is we built a dashboard. I forgot to say this COVID detection system is a cloud computing detection system that actually can hold and handle millions of people. 3.8 billion people on the planet have a smartphone. And if we pair a smartwatch for that, we have a health monitoring system for half the planet. And I know if we can start adding microsampling, we're going to take measurements to a whole different level, way beyond just the millions people are talking about now, all in the convenience of their home, which is where you really want the measurements, not in the doctor's office where they're shifted anyway. But nonetheless, at home, we can pull in all this data. We can pull in your wearable data, your clinical data, your microsampling data, and display it on a dashboard at whatever resolution you want, like daily, weekly, monthly, yearly, what have you, so that you can actually follow what's going on. This is built by Amir Balmani. And then once again, the way we spin this off, I think academics are great at discovery. We're great at proof of principle. We're terrible at actually scaling. We think we're good, but we're not. So we spin this off as companies, and I've founded quite a few over the years. The one in boxes are directly relevant to the work I talked about today, and I want to highlight a few of them here. I mentioned QBio, which is doing the medical version of what I just showed you. With the microsampling, there's Rhythm, and Ryan Kellogg and Jennifer Curtin are here. You can actually learn more about this. In fact, they're doing getting some control samples. You can feel free to give some of your own from your, if you like, with them. They'll be in the innovation lab. And then there's another company called YOLO that's also doing the microsampling that actually does a deep medical metabolomics profile on you for wellness. And you mail it in, and they'll give you back a report on this. We also have a CGM company, that's January AI, that does CGM and a behavioral modification program. And once again, it's very eye-opening to see what kinds of foods spike you and what kinds of activities can suppress or actually enhance that spiking. And then they've also actually set up some mitigation by having a supplement that has fiber, probiotics, and polyphenols. It's a blend we spent 3.5 years building to try and actually improve people's metabolic profiles. So this is some of the things that we're up to. I'm very fortunate to have an amazing team in the lab. And this is just the wearable team when it was at its peak up top. And then once again, the microsampling team at the bottom. Do seek out Ryan, who's here at the meeting. You'll hear a little bit about mental health. That's a different side of this. I haven't presented any of that from Ariel Gantz later today. And so that's the story that we have to tell you. Happy to talk with any of you later. Okay.
Rockstar. Amazing work. I mean, you kind of been the N of one to start a lot of this work. You know,
yep.
Lyme disease, you're picking up your diabetes, the ability now to do multi-omics is at its early stages. This has huge implications for public health, right?
We think so.
What might be your prognostication of what's next, 5 and 10 years, if we had this at scale?
Well, we'd like to, as I say, I think commercialization can make this cheaper. Things that are missing up here, mental health is an area we'd like to move into. I forgot to mention on my devices, you may notice this is an exposometer. I'd like to see us measuring airborne exposure. You have no idea what you're breathing right now if you think about it. And we want to measure that and try and get the good things in and the bad things out. I think wearables are great. As you can tell, I wear 4 smartwatches, and my hearing aids are actually sensors. But I actually think implantables may be the future. They're a little more convenient. So I think they're coming down the road. There's a lot of issues with them, but I think they'll be pretty cool.
How about just the invisibles? The ambient environment can sense you as well. You don't
right.
need a wearable.
Yeah. Well, again, I think we do measure temperature, humidity. That's on this device as well. But I'd like to measure all the biochemical and biological exposures. That's what this particular one does. Not real time. I can't tell you right now what you're breathing, but later I'll be able to tell you.
The exposome. So you're at Stanford, amazing institution, but still doing things in many old school ways. What are the opportunities to put this into clinical workflow, as Ron talked about as well, so that these scales to impact?
Yeah, that's the hard part. I mean, there is medicine's very conservative, which I don't agree with, but it makes it hard to practice. So you have to show it works. I think the US is at a huge disadvantage because our system is fragmented. The incentives aren't aligned to keep people healthy. Nobody gets paid to keep you healthy. They get paid to treat you once you're ill, so we've got to fix that. I think that's where we got to get employers involved. We need new creative models so that people will actually pay to keep you healthy. Maybe you get a discount on your insurance if you wear a smartwatch and hit your 10,000 steps and don't cheat. There are ways to tell if you're cheating with your smartwatch, by the way. So I think we can come up with, that's the number one thing, solve the payment problem.
Yeah, I think we don't practice evidence-based medicine, we practice reimbursement-based medicine.
Right, yeah, and actually, the single-payer systems like Canada, Israel have a much better, they're better aligned to be able to implement this kind of stuff than the US is.
So I'm excited to bring Ron Ballister back out here.
Okay.
I think you guys have a lot of synergies. There'll be a breakout workshop with 2 of them and others later today. But Ron, you were just listening to Mike, and you had some aha moments and things you're also doing at Clalit. Maybe something that sparked potential collaboration or convergence.
No, I think absolutely. I think that the key thing is that none of us can do this alone. I mean, we all have teams of amazingly talented people, and I've been blessed working with some of the brightest minds in Israel. But you never have enough capacity to tackle all of those problems. So I think by being able to join forces, we can do so much more together, and I definitely see that happening. Just one example, for instance, at Clalit, we've put forward an app for all of our patients to download, basically, that allows them to track their physical activities, their steps, fit with their Fitbits, etc. They actually gain points for every such activity that they're doing, and they can buy those actually smartwatches with those points. What we saw, one, is that we managed to do this in an addictive way. So we used kind of the Netflix behavioral economics this time for the better. You know what's the biggest enemy of Netflix? Sleep. So they have found interesting ways to prevent that from happening. So we try to use the same approaches and try to get our patients to do the right thing and to make it easy. And then what we saw there's a measurable decline in chronic morbidity for those who are actually increasing on their physical activity. So again, exercise is medicine. We say this again and again, but it's actually working.
I saw one area of synergism, which is you had this COVID detection, your AI method, but actually if you put in the pre-symptomatic jump up in resting heart rate, you would actually have even better detection than what you're doing now. So I think implementing some of what we're doing with some of what you're doing is good. Suggestion for you, Dan, this late dinner, it's not so good for people's glucose levels. You're supposed to get 3 more hours before you
That's next.
Before you go to bed.
Sleep can wait.
It's not a big deal. You just stay up late, right? Yeah. That's your retort. Yeah.
So part of this now, this new era will be, I think, what you're doing with QBio and some of your work is now this idea of a continuous physical exam. It's not the spot check once a year. You'll get that little proactive alert. That's something, you might have COVID, you might have Lyme. How do you build those into the health systems of the future?
Would you want to take that?
Yeah, sure. I mean, first of all, a lot of the devices aren't approved. They're just starting to get there. But you really have to run proper studies for the FDA to approve them. Until then, it's a little hard. But I think that's what you have to do. You have to show it works. I think, and you want to reduce the false positive rate. I didn't get into this, but others have shown that you can actually pick up AFib from a smartwatch. But it's a pretty high false positive rate. So it does work. But it does go off a little bit more than people would like to see. So I think we've got to get these things tuned better. I think that's early days, so I think that problem will be easily solved. But I think showing it really works and then getting it approved will then get it to scale. And of course, in the US, it's a matter of getting reimbursement, Medicaid.
I can only echo that in the sense that this is really taking us to the choosing wisely domains. You know, there's many, some say up to 30% of the practices and procedures we have in healthcare today are non-value adding. Some of them are just zero positive impact. Some of them are detrimental.
Heart rate in the doctor's office. Everybody's is up.
So there are multiple examples for things we actually actively do and we should stop doing. And when you're talking about these types of early detection and the false positives that are mentioned, you would in many cases be in that domain of healthcare very quickly. So it's not only showing that you can predict something, you need to actually show that this prediction leads to a beneficial impact that on a population basis and in the real world actually improves health. And I don't know it's always the case. So we really should go through the process of a learning healthcare system that I've shown before, try it in silico, then try it in some subgroups, show that it actually has a meaningful impact at the end, and then scale.
So speaking of scale, we've got amazing individuals and organizations here, Genomics England, work from Lee Ray Hood and others. How do we better connect it out so you're being synergistic, not competing, whether it's the All of Us trial data, the Verily baseline information, stuff out of Stanford, Cloud. Is there an opportunity to create kind of the NextMed superconvergence so we're not reinventing the wheel?
So I'll go first. I think that we seems like we all have the same process taking place right now. We have a bunch of people. Sometimes it's 10,000, sometimes 100,000, in some cases it's almost 1 million. But that's where we are all at, and we're trying to assess what is impactful for their healthcare. Properly planning this is critical, and any insights that come from other systems that say maybe you want to tweak it that way would make a huge difference because it's such a huge investment in any one of those cohorts that if we can join our learnings at the point in which we plan and execute, that would make a huge difference at the end of the line. And for those patients who are actually volunteering to those proactive and omics-driven assessments, I think that could make a real impact.
Yeah, 100% agree. The number one problem is data sharing. And a lot of people say, well, patients want privacy. It's not the patients, it's the researchers. They hate to share data. They don't admit it, but it's true. So I think we've got to get people to share data better. I think because also we come at it from different angles. Like what we're doing is super, super deep, much deeper than all of us, probably a bit deeper than what you're up to. And so they actually bring in complementary information that can be incredibly valuable. So you can get ideas from one kind of data and try and validate them in another data set. So I think data sharing is the number one bottleneck in our field. And I think if we can get, I think you can't have enough cohorts. So I think it's wonderful that all these things are coming out so that we can, now we just got to be able to access each other's data.
So I think we have some advancement in that domain as well. It is the hesitancy that was mentioned, but I think there was also true worries of cybersecurity and privacy maintenance. But by now, even Clalit has a data sharing platform that is secure and allows us to collaborate with our friends in industry and in other healthcare systems in order to better improve the cycle of innovation. And so this is like an open invitation to all of our friends out there who are interested in doing and co-designing and implementing together. It is possible now these days.
Yeah, many patients or humans want to be data donors. They kind of build that Waze or Google Maps. When they share data, they have their own map and journey can be.
Nearly all of our data is open access, which are that people are willing to put, including their genome sequences. So people are surprised you can literally go up there and download the data. And a good example, though, on the data sharing is there's a lot of publications out on wearables now, and both glucose monitoring and on smartwatch data. And if you ask for the data, which we invariably do, we've gotten a total of 0. Nobody's sharing that data. And they always blame it on data privacy, but it's not really data privacy.
So we might need to reinvent HIPAA. Last 30 seconds each. What are your needs? If you want to ask this community about what you need built and what your unmet pain points are, what might they be that you'd ask this community to help build?
I'll go first since you're hesitating. We want your data. Sign up in our studies. We have all kinds of studies. If you're Bay Area, there's a whole ton of studies for you. If you're elsewhere, there's several studies for you. No, I think because we'll learn from all this data we're pulling in, because we are also different, that we want to be perfect in disease detection. And I know we can do it. It's just a data problem. It's very solvable.
So we don't want your data. We're drowning in data. Make it stop. What we actually would like is for the brilliant ideas, and even more important, the brilliant applications that can actually have went some of the way in turning data into insights, and insights into practical, actionable, meaningful implementationable actions. And if you have that, if you have the prototype of that, or if you have that something working, talk to us, because we would really like to try it out and to see whether we can improve population health with your brilliant ideas.
Awesome. Data to insights to action. Thank you, Mike Snyder. Take you, Ron Balancer. Wow, I think we could have them here for the entire 4 days. They're a great example of building the future next. We're going into a very synergistic session, session 7, Future of Digital Health and Medicine. Again, from sort of inception to impact. It's sort of been a bit of a buzzworthy field, but now we're seeing digital health really go mainstream, from consumer wearables to the medical applications to digital therapeutics and beyond. So really pleased to bring out my friend and co-conspirator, Prisa Vatanka. She's a pharmacist, but also a real leader in the realm of digital health and medicine. And she's going to lead off the session on the future and the current state of digital health and medicine beyond. Prisa.
Wow, it's incredible to be here with all of you. Look, we are still just at the beginning, right? We're just at the beginning of realizing the full potential of digitally enabled care, right? We've got individuals who now will be experiencing a healthcare system that isn't evaluated just on the treatment of illness, right? But instead, a healthcare system that's also focused on prevention, right? One that's designed around the person, not the clinic. And as a pharmacist, this is what drives my passion for digitally enabled care. This is what has driven all the work we've done in trying to build awareness about the tremendous power of these technologies to transform how we deliver and access care. So here I am with you. You are the visionaries. Right? You are the innovators, the thought leaders. Many of you are at the forefront of innovating and creating and adopting these new technologies. And you understand the power of these technologies to really take us to a new era of health and care. Importantly, you understand that it's not just the technologies, but it's that human element. So, what's now, near, and next in digital health? We've heard from some incredible speakers these last few days. I'm going to give a window into a little bit more about the now, and then I have the honor of inviting some other digital health luminaries who will build on the now and give a little bit more on the next, the near and the next. So, what's happening now? Well, there's been an explosion of digital health products and solutions. We have some regulatory pathways now to help us to understand and be able to validate safety, efficacy. Some early commercialization models have emerged. And we are starting to see some adoption, certainly in the last few years. We've had an impromptu pilot, right? A scaled demonstration around the globe of how these technologies, such as telehealth and remote monitoring, can be used to maintain access to essential services. So, an important thing that we gained through this impromptu scaled demonstration is that there's tremendous value in this continuum of in-person and virtual care. Not one or the other, but this continuum, right? Really meeting individuals within the context of their lives, their needs. But what's happening? In some ways, the emergence of all these technologies is really outpacing integration in clinical practice. So as Daniel was sharing yesterday with our team, we've created Digital.Health. It's a platform bringing clinicians and these solutions together. It's a way to enable all across the healthcare ecosystem to explore, discover, and learn about these different digital health products and solutions and how to integrate them into the care they provide. So here's what I believe. I believe that there is great power in building on this innovation and driving meaningful change in healthcare. And I believe that we can create a more equitable, healthier society together. So, I have the distinct honor of introducing our next three speakers. Aside from being digital health luminaries, we have an Olympian, we have a push-up enthusiast, and we have a former urban planner. So we will begin with someone who has been called the father of digital health. He's the founder and chief medical officer of AliveCor, the creative genius who came up with the cardiomobile EKG device. It's really creating this opportunity to conduct EKG anytime, anywhere. So, without further ado, I'd like to introduce the one and only Dr. David Albert.
Thank you, Perusa. Good morning. Let me see here. What do we got? We'll get there. Maybe. All right. We are having technical... Aha! So I was asked to talk about innovation and how you make innovation deliver an impact. And I've been doing that. I'm old. You know, she said I'm the father of digital health. John Nosta said that. That's actually not true. I'm the grandfather of digital health. I have grandkids now, so you know I'm old enough. And why should I do this? By the way, bow tie. It's how I roll. Dan said no suits. I'm not wearing a suit. So I began over 40 years ago at Duke, where I was in medical school and biomedical engineering grad school. And because of some family health issues, I accidentally became an inventor. And I've got, you know, I actually have some opinions. And even the President of the United States sometimes agrees with my opinions. So this was my first peer-reviewed paper. It is 40 years ago, 1983. Does anybody know who the second author is? That's the commissioner of the FDA, Dr. Rob Califf. So Rob actually taught me how to write papers, and that's a pretty good coach. And this is my first patent 40 years ago, a wrist-based heart monitor with an array of pulse tonometry sensors. If you go in and you see LifeMetric, you'll see something that is a modern version of what I did 40 years ago. But that's then. This is now. AliveCor began in 2011 And today we have over 3 million lifetime customers. We have 1 million people every day. In fact, every week we receive over 1 million ECGs into our cloud. We have 190 plus peer-reviewed publications, and we have over 190 million ECGs in that cloud, again, going up 1 a week, 1 million a week. Well, this is the idea that I had for AliveCore. It was in 1996. I had a company called Data Critical. Ultimately, it sold to GE Healthcare in 2001. But I got a patent. I got an FDA 510K. I built a product, and we never commercialized it. Why? Because it was a Rube Goldberg mess. It had wires and cables and a pocket PC and a cell phone. It was not a practical solution. Fast forward to 2007, when that eureka idea and the notion of, oh, by the way, Steve Jobs saying one more thing, and we had the smartphone. The smartphone is the remote control for our lives. We bank, we travel, we monitor our health, as Mike Snyder talked about. It is the center of our life. You walk around, I was just on the subway in LA, I live in Santa Monica, and everybody on the subway is looking down. Almost everywhere you go, everybody's looking down. And I took advantage of that in 2010. People told me, oh, by the way, people who need heart monitoring, they don't have smartphones. That was then. This is now. So how did I come up with this idea? Well, I have a notion of I call orthogonal thinking. And that is I reject conventional wisdom and I try to look perpendicular to what everybody else is doing and thinking. And that gives me the opportunity to see things in a new way and to do this thing called innovate and invent. And so that happened. Built a smartphone case, made a 4-minute video that I sent to 3 people. And I just happened to upload it. When I uploaded it to YouTube, I happened to click send to my LinkedIn connections. 2 days later, I had 400,000 views of that video, and it became viral. And this was a virus, unlike COVID, that was actually beneficial. So in 1924, Wilhelm Einthoven won the Nobel Prize in Medicine and Physiology for the first practical ECG machine. That's on the left there. And you had buckets of salt water were your electrodes for the left and right hand and the left leg. And today, we can give you the same 6 limb leads using a device you hold in your hands and on your knee. That's where we've traveled in almost 100 years. But when I first started AliveCore, we didn't have an FDA clearance. So what did we do? We sold it to veterinarians. And here are some dogs, cats, horses. In fact, today, almost every track veterinarian around the world uses a Cardia device because racehorses get atrial fibrillation when you train them too hard. But as you can see here, that's in the Cincinnati Zoo. They trained a gorilla who happened to have an arrhythmia. I'll give you a banana if you put your fingers on the Cardia. And so these are just some of the many, many kinds of animals we used the first year. We innovated our business model before we had a 510K. So then, what happened? Well, we got a 510K, we began selling, and as everybody knows, we have a few customers. That's one of our customers. I don't know if you know that guy, but you can look on the back of his phone, and what does he have? He has a Cardia. And I can tell you, we got to where we are today when we have the world's biggest companies as our competitors, and we are growing exponentially on 3 basic ideas: clinical validation, and clinical validation. What do you think I base our success on? There's a hint. So, does everybody know what the FDA actually regulates? Well, they regulate your claims, but they regulate on the basis of safety and efficacy, and you've heard that before. You have to prove both to them when you have a new innovation. And I would tell you that evidence-based medicine and clinical practice guidelines are things you cannot ignore. Workflow are things you cannot ignore, even if you're coming outside the established medical practice. So what have we done? Well, I told you we have over 190 peer-reviewed publications. Here's our first published study, was an abstract at the Heart Rhythm Society, and this is one of our more recent ones in June of 2022, compared our device to a device from some unknown company, and that's our 6-lead ECG. We publish, we support research, we validate every innovation we do, and that's why we're able to compete with anyone. That's why Mayo Clinic is an investor. That's why GE Healthcare is an investor. That's why Qualcomm's an investor. And that's why Omron, the people that make all the blood pressure cuffs, are all investors in AliveCor, because they know we are the clinical leader. And so this is another paper. It was from last summer, showing comparative rates of AFib diagnosis. We know more. Why? I got 190 million ECGs. About 15% of those are AFib. What's that mean? That means 25 million AFib recordings from over 1 million different people. That's big data. That enables machine learning. That enables deep neural networks that perform better than a cardiologist. So this is another one of our papers. This shows that we're not just limited to atrial fibrillation. This is something called QT. Now, most of you probably don't know what QT is. QT is a measurement of the EKG, but it's very important. As a matter of fact, during COVID, remember when people were telling you to go take hydroxychloroquine and azithromycin? That's Plaquenil, and that's a Z-Pak. Well, both of those medicines actually prolong the QT. And if your QT is prolonged enough, you can have sudden cardiac death. And so monitoring your QT is very important. Today we're involved in studies. UCSF has one in South Africa. Why? Drug-resistant tuberculosis. All the drugs used to treat it are serious QT prolongers. Methadone, serious QT prolonger. Every antipsychotic medication is a QT prolonger. So lots of opportunities. You don't want to have to bring people into the hospital to just do one measurement. You want to be able to let them live their lives. And so, in addition to medical efficacy, you have to have economic efficacy. We've talked a lot about it. You know, healthcare in the United States is incredibly expensive. And so to be an innovator, you need to innovate economically, not just clinically. And this shows you, we've actually had studies that we weren't even involved with. This is from Jefferson University in Philadelphia that showed that by using Cardia, they could keep people out of the emergency room and they could keep people out of an urgent medical visit, saving real money, helping those patients to live better lives. And these are some of our many partners. I told you Mayo Clinic's an investor, but all of these are active Cardia users. And all of these drug companies were involved in many, many drug studies all over the world with the world's leading pharmaceutical and CROs. And of course, I'll be honest with you. Yesterday I had 4 people come up to me and tell me about how they've used Cardia to help their own family. It made my day yesterday. That's at this meeting. So we have people every day who message us saying thank you, and that makes it worthwhile. So this is our path of innovation. Some of you may have seen the card on the right. You can come up and see me. It's a credit card, literally the size of a credit card. It's the thinnest EKG in the world, and it has microprocessor, Bluetooth, analog electronics, and this is it. You can see how small it is, but this is the future. The future is, instead of having to go to the hospital, we'll be able to diagnose you that you're having a heart attack anywhere and any time. That's innovation. Thank you.
Hello, let's have a little chat.
Okay.
Wow, tremendous. So you're the OG tech go viral person. You were really creative when it came to finding an early niche with veterinarians.
Innovating a business model.
That's right.
Okay? When you're broke and you have limited resources, you have to find a way.
Yeah. Completely. And I think that's really good insight for those out there with startups. There's never no, it's just finding that other way around. And it's been incredible to see over the last decade how your already tiny technology has just continued to shrink. So amazing. I know as a pharmacist, we were delighted when we did a pilot using the KardioMobile, where pharmacists were able to test and do an early detection and referral. So there's so many use cases for your technology. Certainly it catches my attention when you talk about the QT wave prolongation. So you can
certainly pharmacists understand that. I mean, we want to help people practice at the top of their license, whether they're a nurse, a pharmacist, a physician, a PA. And we want to bring healthcare to the individual. So
absolutely.
Everyone can innovate.
That's right. So one final tip for those out there innovating in your shoes, what would be your singular recommendation?
Think different. And that was what Steve Jobs said. And by the way, it's really think differently. But by saying think different, he gets you to think. So, ladies and gentlemen, go out and innovate.
Beautiful. Okay, next I have the pleasure of introducing Herco Koemans, who works with the Dutch Ministry of Health, Welfare, and Sport. And he does tremendous work as a thought leader and really bringing different strategic groups together, and really does a lot in terms of implementing programming for public health. So I'd like to welcome Herco to join us. Okay. Thank you so much.
Thank you. Thank you. So I'm Herco Koemans. I work at the Dutch Ministry of Health, Welfare and Sport as the International Digital Health Policy Officer, which actually is way more fun than it sounds. And we've been hearing so many brilliant perspectives and stories here these past few days, and we will hear more. And I'm here to bring two other perspectives to this mix. One is from Europe, where we're all from here, and there's lots of Dutchies here. You've probably heard them quite a few times already. We're kind of loud. And the other one is from government, which I think is very important to have a voice here as well. But first, I want to go back to the starting point where a lot of this change is accelerated from. The price of the pandemic was that almost 7 million people lost their lives, which is of course terrible. And if we look at the graph, which is the excess mortality rate, we can see that almost 18 million people also lost their lives, not directly from COVID probably, because we don't know for sure, but mainly because our health systems failed globally. This is the price that we paid. And we all know now that healthcare is broken. And we've heard all these stories here. And also because of the stories that we hear here at NextMed, we also know that there is hope. Because one of the things that this crisis has done is that it brought everyone together, and like we are here today and these days as well. So there is a lot of good happening. And one of the things that we see is that there's a tremendous amount of resources being put into this space right now. And this is just a few numbers from the European Union with the Recovery and Resilience Fund that they created right after, I think this is from 2021. And you can see the amounts that are in there. It's huge. It's really huge. So I think currently it's one of the most interesting times to be active in this space, because there is an unprecedented alignment of the major planets. You have to look careful for which planets they are. But one is that everyone now understands globally the sense of urgency and the need to change. There's also more money in this space right now than we're ever able to spend wisely. Note the wisely. the politicians are now some of our biggest advocates for this change, which never happened before. And this also means that every country now is looking at structural reform of their health systems to include digital and data and technology as a foundational pillar of the healthcare systems of the future. And last but not least, the technology has also shown that it's mature enough to be deployed at scale. And these things never came together at this level globally as before. So this is a really, really interesting time. We also see that everything is happening everywhere all at once. I love this movie. They earned the 7 Oscars that they got. But, I mean, it's very difficult to manage it all and to find the right path through all that and to navigate it. And this is because the stakes are now so high. This is about the healthcare of the future. And this is about the next 100 years, like we heard yesterday. So this is one of the reasons why government, and this is our national parliamentary building, the little tower on the left there, I'm sorry, on the right, that's our White House. That's where the office of our Prime Minister. The rest is the Parliament building. But one of the reasons for that the stakes are so high is that government is now taking a bigger role in this. And this isn't just in the Netherlands or in Europe, but this is everywhere. And one of the things that governments are tasked with is to ask the uncomfortable question that innovators like yourself don't really like, but is everything that you do also beneficial to our societies? Do we really need to do everything that is possible? And that's one of the big roles that we do. So I love my job. I get to travel around the world and meet wonderful people like yourself and be able to share our insights and our views to people like you. And in 2019, I was at South by Southwest, and I met this wonderful guy. I don't know if you know him. His name is Dr. John Cohn. He's an IEEE fellow and the IBM IoT guy. He is like the quintessential Uber nerd. And those aren't my words, those are his words. And he said something that really resonated with me there. And he said that we are at a crossroads. And it's either technology shapes society or society shapes technology. And we want, of course, society to shape technology and to use that to make us more human. Because that's our core driver as humans. And the interesting thing, he said that for this, we use something that's often seen as very boring, but is actually quite exciting, and that's standards. And because standards aren't about technology, they are about translating our common civic values like trust, freedom, safety, autonomy, solidarity, into requirements for how that technology is to be deployed and used within our society according to those values. So it's actually answering that question, when is it good enough to be beneficial for our society? So now on to Europe. In December 2019, there was a very ambitious new European Commission that was facing the aftermath of a huge crisis, which was, of course, Brexit. And if there's Brits out there, we welcome you back anytime. But the thing was that they want to make sure that no other country would ever leave the European Union by integrating more and more. And before they knew it, remember this was December 2019, before they knew it, they were neck deep in the next crisis, and that was a healthcare crisis. And you have to understand that healthcare is what we call a national competence within Europe, which means that the European Commission has no say in how we design, deliver, or regulate our own healthcare systems. But with this crisis, we found out that we cannot fix this problem by ourselves. So we have to work together, and this is why we have this union to work us through that. But they also did another thing. They created a European data strategy that is built on 4 pillars, and they call it the Digital Decade 2030. And the pillars aren't that interesting now, but take a note of this one in public services. It says that by 2030, everyone in the EU should be able to have access to their digital medical records throughout the 27 member states. This, of course, is easy to write, but they built that ambition on an ongoing process already with different regulations and different processes already and initiatives. And one of the things that they're really doing right now, which I personally think is brilliant, they have what I call the European Big Six, which is 6 big legislations like the GDPR, which goes into effect across the entire EU on data governance, data ownership, and data agency, if you will, control over who gets to do what with your data, on how the market operates, how do you create a fair and open market, on artificial intelligence, similar to what we've done with the medical device regulation, so it's market access for algorithms. And one that's very interesting is called the European Health Data Space, and I will go into that just slightly more. So the strategy that they are developing right now and are regulating is to create a global leadership. So they are raising the bar globally for this. And to create a single data market that operates on all these areas and very much on translating those common civil values into regulatory frameworks that will apply to all member states. So the European Health Data Space Regulation, this is a lot of text. This is my only slide with a lot of text. It basically does 3 things. One is make sure that citizens get access to their health data everywhere within the European Union for better care throughout the entire Union. So if you live in Germany, you can get cancer treatment, oncology, and in Romania or wherever you need it, wherever the best treatment is available. It also wants to harmonize the European EMR market, which is a very big challenge, but they are regulating standards and security and all these kinds of civic values for the EMR market, and they want to make the same data available in a future-proof infrastructure and architecture for secondary use, for innovation, for policy making, and for research. So just to give you time-scale ideas, so the European lawmaking process is like very complex. It's got to do with the European Council, which is the member states, and then the Parliament, and they have to negotiate, and it's all political. But the European Health Data Space is currently in discussion within the Parliament and in the Council. The others are already further down that line, so it's actually going fast. And just to give you an overview, the GDPR took 7 years to negotiate and then 2 years extra to go into effect. The Data Governance Act took 10 months to negotiate. 10 months, and this is at least as fundamental as the GDPR. So everyone wants it. So the sense of urgency, the political will, the capital, I mean, this is already there, and this is like the regulatory framework in which to do all that. And this is Nick Fosbury, and he died this week, so I wanted to honor him. But it is raising the bar, and that's basically what he really did, raise the bar, and this legislative framework will raise the bar globally. Because if you remember what the GDPR did, first in Europe and now even here in the US, there's talk of a federal privacy regulation to combat the 21 different state privacy regulations. But all these countries are using that as the golden standard. So this will raise the golden standard everywhere. And they use health as the first topic to do that in. So it's not just health data, but it's using the digital identity to be able to share the health data. It's cybersecurity rules, it's cloud computing, high-performance computing, privacy, skills, all those things are now focused on health. And this is the next, but it's already being built, and it will all be ready probably around 2030, where we have this European market that everyone can use to deliver their innovations, to deliver your solutions in a way that society needs them to be. Thank you. That's my...
Thank you so much. Incredible what you're doing to harmonize EHRs. So I think there's a lot we can learn from you. So thank you so much. We have to stay in touch.
Yes, thank you.
Thank you. Okay. All right, next we have, I don't know if you've been trying to figure out who's the Olympian, who is the push-up enthusiast, and who is the urban planner by background. So this one's the Olympian. So we've got Jen Goldsack. She's the CEO of the Digital Medicine Society. I've always been in awe of how prolific that the DIME group is. They are constantly creating all kinds of tools and resources to really help to create a common framework and language as we are building this space and learning how to integrate at scale. So without further ado, I'd like to introduce Jen Goldsack.
Athlete, right? I'm not sure I convince anyone right now that I'm an athlete, but this is a big rehab milestone because I'm supposed to be on crutches right now, so it's a few risky behaviors to be with you. As Risa said, Jen Goldsack, CEO of the Digital Medicine Society, or DIME, and a bit of a challenge to cover digital health and medicine from inception to impact in 8 or 9 minutes, but we'll see what we can do. I'm going to take an approach of telling a few stories, but before I do, let me just tell you a little bit about DIME. For folks who don't know us, we are a global nonprofit. Our mission is to advance the ethical, effective, equitable, and safe use of digital technologies to redefine healthcare and improve lives. Importantly, we are tech enthusiasts, not tech determinists. Our goal is not to try and shoehorn digital technologies into every nook and cranny in healthcare, but rather what we are trying to do is think about how can these new digital tools in the toolbox really improve and address some of the most pressing and persistent challenges that we experience in healthcare. So let's dive in with some of these examples. I want to take you back in time. I think we can officially call this the before times. October 2019, our organization launched a crowdsourced library of digital endpoints that were actively being used to answer questions about the safety and efficacy of new medical products. In October 2019, we found that there were 12 sponsors who were using 34 digital endpoints, and that nearly half of those were positioned in phase 2 and phase 3 when it was a drug or a biologic, and that nearly a third or nearly half of those were positioned as primary endpoints. We thought this was incredibly exciting. We thought, well, gosh, this isn't, the stuff of the future. This is here now. We got so excited. We wrote a Stat News op-ed about the whole thing. But where are we now? So we maintain this, we update this library every quarter, and when we look today, we see that 104 sponsors have collected endpoints. We can see that nearly, or just over 2/3 of them are being used in phase 2 and phase 3. We can see that 1/3 of the 378 unique endpoints are positioned as primary endpoints. This is absolutely extraordinary data, and so we can look at not only the increase in the number of different endpoints, but we can also look at the adoption, the enormous embrace by industry of these measures over the last 3 years or so. But I want to come back to this idea of, what was it? Let me see if I can figure out how to go back really quickly. Yes, 378 unique endpoints. I'm going to go ahead and make the case that there aren't 378 interesting things to measure about an individual's health. And what you'll actually see if you go into the endpoints library is that there are over 80 unique measures of physical activity, over 50 unique measures of sleep. And there's a point at which we need to think about harmonization, and we need to think about what's the best measure for determining someone's health or disease or status in their condition, as opposed to what's the Me Too product that I could put onto the market. I think this is really, really important, and we need to make sure that we are not just moving forward with volume, but we are moving forward with intent. And when we think about this, it's not just the measures. I'd argue that while the ability to capture data around someone's experience of their disease, both in and out of the clinic, is an absolutely enormous trait of the digitization of healthcare, we have to think about the broader landscape. We have to think about the use of all the digital tools in the toolbox, and we have to think about them working together to return outsized impact across the entire drug development continuum. If all we're doing is shoehorning remote patient monitoring into clinical trials as they exist today, all we're doing is adding inefficiencies. We need to fundamentally reimagine how we develop new medical products. I think this is absolutely critical. And the second story I want to tell, and I'm really conscious that I'm standing really still, so I apologize. The second piece I want to mention is the sort of the corollary, if you like. Someone just threw my crutches, I literally heard it. Is the corollary on the healthcare delivery side of the house. So here's a table that, or a figure that many of you might have seen vis-a-vis the use of remote patient monitoring in healthcare delivery. So for folks who are not from the US, CPT codes are the way that we bill for healthcare. So if you look at the different billing that goes in, that's a really nice proxy measure for what kind of care is being delivered. And when you look at this nice exponential curve, this looks tremendous, and there's nearly a 2,000% growth in RPM in 2 years. There's two things that are important. One, that's between 2019 and 2021, and I'd argue there was a pretty big exogenous shock that happened during that time that makes that data, you know, perhaps not representative of current state in healthcare. The other thing is there's no scale on the y-axis. So this is a classic case of lies, lies, and damn statistics, right? So remote patient monitoring went from infinitesimally small to just a very little bit of it, despite the enormous increase. And it's really interesting to think about that now. In an era where we are trying to do as much as we can on the healthcare side of the house to generate revenue, the fact that there are 4 CPT codes that providers can use in order to bill for remote patient monitoring, and it's barely being used, tells you something pretty damning about the state of the tools and technologies. Now remember, I come from an organization called the Digital Medicine Society. I really believe in these tools to improve the way that we care for people. But I think there's a couple of things that are fundamentally wrong about how we are developing these products and introducing them into care today. In terms of how we develop the products, at Dime we spend an awful lot of time creating evidentiary frameworks around the integrity of these products and the claim that they make. Actually today, which is the reason I put a project slide up, we are launching a new product to take our V3 framework, which is the broadly adopted gold standard for evaluating digital measurement products, and adding considerations around usability, human factors, and human-centered design. We aren't great at making products that are either great for the end user, great for the clinician and their clinical workflow, or great for the people trying to use the data. And we have to address it if these things are going to go to scale. Then similarly to what we see on the medical product development side of the house, we're pretty lousy at integrating these individual point solutions into a broader tapestry of digitized healthcare. We aren't really thinking about how we actually build and create a reimagined system of care rather than just putting extra tools, extra burden into the existing system that can barely bear any further burden whatsoever. So here's an interesting resource. So we've had a partnership with our colleagues at VA for nearly 3 years now, and last year we put out a playbook on digital healthcare. So bear in mind that our colleagues at VA pay for healthcare a little bit differently, but that actually affords us an opportunity to really think about what does it mean to build healthcare around the person, the patient, and not the clinic. And similarly, and you're going to notice, and not by accident, that the next slide mirrors, if you like, a little bit of what we were reviewing in the life sciences. We have to think about deploying all of the tools in the toolbox in a really synergistic and integrated way, not just to solve an individual solution at an individual point at time, but we have to think about all the different functional applications and the different ROIs that these tools, when combined, when done so intentionally, can bring to a reimagined way of caring for people. Currently in healthcare, we sit in the clinic waiting for people to arrive sick on our doorstep. Then we think good healthcare is how good are we at sorting out that mess, when that person might be more advanced than they could have been, when they might be more expensive, complex, and when the health inequities that we know exist within our community are fully exacerbated. So I think I did it. Yes, 35 seconds. This is what I'll leave you with. When we think about the promise of digitized healthcare and across the entire continuum, we don't think of a world where there's a silo of research over here, there's a silo of medical product development here, there's individual health promotion, and there's healthcare delivery. We think about a very different future where all of these things are fully integrated, powered by flows of data. And we imagine a future healthcare system that's defined by an individual's health and not by how good we are at treating their illnesses. So with that, I'm going to slowly, I think, hobble off, and happy to grab any questions during the break if that helps. Thanks, everyone. I might need my crutches.
Yeah, you want the crutches?
I do.
Okay. Crutches. Sure.
Also, I'm going to take my crutches because I overcooked my goose, and you don't want to see me wipe out. Thank you.
And, tell us, you know, as I've heard you talk about advice to startups as well,
yep.
right? And so this idea of not the race to regulatory, but there's like several things we should be thinking about all at once.
Yeah, I think that's exactly right. And so we've just completed a body of work at Dime, actually in partnership with our colleagues at FDA, to really try and define the different regulatory pathways for medical products here in the US. What we're starting to find, and the messaging that we're trying to promote right now, is that regulatory strategy is absolutely critical to good business strategy. If all you're doing is trying to do gymnastics to avoid regulatory oversight by FDA, there's a very good chance that the full intended use of your product, the full population of individuals who could benefit from your innovation, and quite importantly, the different income streams, the different reimbursement pathways, you are cutting those off if you aren't actively thinking about regulatory strategy as core to good business strategy. And when you do that, it drives you towards thinking about the opportunity to have an integrated evidence plan, when you aren't just thinking about what's the dossier that we need to hand off to our FDA colleagues, but what's the evidence that we're going to need for those downstream decision makers? What are payers going to ask for? And how can we think about an integrated evidence plan where we're capturing data as efficiently and effectively as possible? How are we thinking about the information that prescribing clinicians are going to need? Pharmacists, as they coach individuals around the use of these tools, how are we thinking about, in the era of mis and disinformation, having really robust evidence to actually, you know, make patients feel confident in this? So we really do think about regulatory strategy as being core to good business strategy, and that catalyzes a very different mindset around what good evidence generation looks like.
Fantastic. Okay, thanks everyone. One more round of applause.
Thank you.
Okay.
Thank you, Risa. Thanks for that great session. Definitely check out the Dime website, the Digital Health website. There's so much coming together, but it needs a lot of thinking and collaboration across the planet. So we're about to go to break into the Innovation Lab. Before we go to break, while we're at break, we have a couple key things that are beginning happening. Number one,
your scrubs. Yes, and actually you get to customize what design that you would like. And the way you're going to do that outside the courtyard in the garden area, you've got these forms that you're going to ask to be filled out, your name, size, and what style you'd like, and they will print them for you, and then you can pick them up. So make sure that you get your order in. You do not want to miss these collector editions, highway to heel NextMed scrubs.
First edition NextMed Health Scrubs. Other element we're going to be doing today, you already have an email from Bina.ai. Download the app. We're going to be doing a fun crowdsourcing vital sign experiment later today, so we want to have that done before the end of lunch, so check that out. Here's a little video let's play that video for a second on what's going to happen with Bina.ai.
that data. Let's make it happen together today.
All right, well, check out that app. Try it out. We're going to do some interesting experiment that's never been done before with that later today. So with that, back to the slides. You have a 30-minute break. Please be back in time. You don't want to miss our session on neuroscience and neuromedicine. Have a great
You want
break.
to be back in right when it starts because there will be some fun things on the stage.
Awesome.
Thank you, I appreciate it. If you're going to applaud, would you run around and make it sound like everyone else is applauding? Hello, everyone. I'm Robert Strong. I'm your magician, and as a lot of you know, I wrote a book called Amaze and Delight, which you guys got when you registered. And magic is all about connection. And each of you are going to have 5 minutes with me right now where it's literally going to change the direction of your lives forever, without exaggeration. I'd like to ask everyone to uncross your legs, put your feet flat on the ground, uncross your arms, put your hands on your knees, take a deep breath, bring your eyes and focus and attention up here. And I want everyone in this room to think about what you need in life for the next stage, the next step, the place where you're stuck. I need an expert in AI. I need someone on supply chain. I need distribution. I need funding. Everybody take a deep breath and distill that to one sentence. I need, fill in the blank. I am stuck, fill in the blank. Get it down to about one sentence. Everybody stand up right where you are. Everybody put your hand in the air. This means I need a partner. So your hand stays up until you have a group of 8 or 10. Mingle around the room, find a circle of 8 or 10 people. When you get to 8 or 10, your hand goes down. Keep your hand up into your circle of 8 or 10. Move your feet, your body will follow. Make a group, keep your hand up until you have a group of 8 or 10, 9 or 10, keep your hand up. If you don't have a group of 8 or 10, look for somebody with their hands up and complete your group of 8 or 10. Once you have your group, put your hand down, bring your focus back to me. This, everyone, is your mastermind group for the next 3 minutes. You're going to go around the circle and say, here is where I'm stuck, here's what I need. And you know the saying, the early bird gets the worm? Well, you guys were on time, so you're getting extra rewarded. If you're just joining us, create a group of 8 or 10. All of you start going around the circle and saying where you're stuck and what you need, and I'll talk to them. Can I get a little background music, please? If you're just joining us, make a group of 8 or 10. Think about somewhere in life, work that you are stuck and you need to get unstuck. I need an AI expert. I need a CTO. I need a CISO. I need a supply chain. Boil it down to just one sentence, short and sweet, and go around the circle and tell everybody what you need and where you're stuck. You have 3 minutes, everyone. 3 minutes. Join a group. Join a group. Pop into a group. If you're at home on the live stream, go ahead and put it in the chat. Where are you stuck? What do you need? Put a link. Ask a question. You can play along at home. Hey, everyone, if you're just joining us, join a group. Join a group. There's about 15 groups around the room. Come on in, come on in, come on in. Two minutes, everyone. 2 minutes. Join a group. If you're just coming in, join a group. Come on in, join a group right here. Right here's a new group. Come on, if you're joining the room, right here's a new group. What's next? You can start telling people how you're connected, how you can help each other. 90 seconds, everyone. If you've gone around the circle, now you can actually start offering help and connections. You can exchange information. This is your mini little mastermind group for another 65 seconds, everyone. Go ahead and exchange information. "35 seconds, everyone. 35 seconds. Someone's got to do it. It's so hard. Okay, everyone, if you can hear my voice, clap 2 times. If you can hear my voice, clap 2 times. If you can hear my voice, clap 2 times. Everybody have a seat. Everyone have a seat, please. What NextMed is about connecting and changing the future, and I hope that 3-minute exercise changed the direction and path for some of you. I hope you enjoyed. My name's Robert Strong. See you tonight. We're going to do a little talk on the neuroscience of magic. I'm going to teach a magic trick, and welcome to the neuroscience portion.
Thank you, Robert. Our magic man. Thank you, Robert Strong. We'll be doing a special Learn Some Magic and maybe Learn Some Magic and Neuroscience tonight in the Coronet Room, where we had the sacred cacao ceremony last night. Of course, magic and the mind and neuroscience and our perceptions are all blended. Can we get folks in the room and close the doors and lock them? No, that's later. So we've covered AI, synthetic biology, digital health systems, but all of this comes together in our brains, and there's lots of new ways to not just read and write DNA, but read and write from our gray matter. And we have a really, I think, fascinating session coming up on the future of neuroscience, neuromedicine, and even a taste of the future of mental health. And I've been lucky to know our next core faculty member, I don't have my clicker, virtual clicker, Divya Chander, since a long time ago. We met actually when we were both in the finals interviewing for the astronaut corps, and then down at Johnson Space Center, and then later reconnected in the Bay Area, where she's a MD, PhD, practicing anesthesiologist, studies consciousness and beyond. Has been on core faculty with me at Singularity University since the get-go, and she's going to lead off, I think, this really fascinating session on the future of neuroscience, the brain, and beyond. So please welcome Divya Chander.
Hey, good morning. So I am waiting for my slides. I'm Divya Chander. As Daniel said, I am a neuroscientist. I'm an anesthesiologist, and I use the operating room as my laboratory to actually map brains as people move through altered states of consciousness. So that is not my first slide. There we go. No, it's okay. And this is animated. Maybe click on that for a sec and see if that, let me see. Thank you. Okay, here we are, opening slide. So what I'm going to talk to you today about, how many people have heard the hype recently about using stable diffusion to mind read? Has anybody heard about this recently? All right, that's what actually motivated the talk that I'm going to give today. So we're going to start with just a little bit of a history of what brain mapping and neural decoding is all about. This is a selfie that Ramon y Cajal, a very famous Spanish neuroscientist, took in his laboratory in the 1930s. And what he did was he would look under a microscope at dead brains, sliced up brains, and he would map and draw these stunning cells. We as neuroscientists owe so much of what we do to this man. And what he discovered is that from different parts of the brain, these nerve cells have completely different shapes, completely different anatomy. And you can see these like hairy things that are kind of these tiny little hairy things, stubby things that are sticking out. Those are dendritic spines. Those are like receiving computational input-output units on these nerve cells. And it turns out that form, computation, decoding follows function. So the shape of these types of cells has a lot to do with their computing power. Now, since then, we have come a long way. This is from the Allen Brain Atlas. They have been trying to map every single cell type in every part of the brain, both mouse and human. And then there's connectomics, the idea that we can actually map the pathways that move from nerve cell to nerve cell, every single part of the brain. And that has all given rise to a static understanding of what the brain looks like. But for actually listening to how nerve cells speak, we need a way to measure their physiology. And what you see on the right is functional magnetic resonance imaging. It's when we stick people into a magnet and we actually watch how the magnet causes blood that is holding up, basically hemoglobin that's holding on to oxygen, to spin differently than when it lets it go. So that's how we use it as a surrogate to understand which parts of the brain are active and which are silent. And there on the left, on your right, what you see is somebody wearing electrodes on the surface of their skull. This is electroencephalography. And this is a way, again, both of these are non-invasive ways of imaging the brain in real time. Now, there have been a lot of new developments. So this is a company founded by Brian Johnson. called Colonel, and he's created a device that can actually, it's portable, and it does a little bit of what fMRI does, can actually look at changes in blood flow in the brain, but it combines the best features of EEG, which is that it's fast and it's real time. And you're going to be hearing from Mary Lou Jepson tomorrow. She has a company called Open Water, in which they are using things like basically wave and phase differences and optical imaging to actually look at activity in the brain, and they're using it for diagnostics and therapeutics. So more tomorrow from Mary Lou. But we're going to start now with this idea of what these things can be applied to. So as Daniel mentioned, I study consciousness, and one of the ways in which I do that is by comparing brains that are in differentially conscious states. So that includes things like sleeping, general anesthesia, and coma. We can ask ourselves, what do these brains have in common, and what's different about them? So this is an example of what I'll do in the operating room. I'll put a set of those EEG electrodes on someone's forehead, and I will watch their brains as they move from being awake and aware to moving through these different transitions and states of consciousness, and then I will apply algorithms, everything from spectral analysis to looking at functional connectivity, how the brain is talking to itself, to looking at its information calculating capability. And recently, actually, my collaborator, Sarah Eagleman, is our next speaker's wife. We collaborated at Stanford on this paper, and we started looking at nonlinear dynamical ways of characterizing brains that were more and less conscious using complexity measures. So then I left Stanford. And the reason I did that is because I actually wanted to apply this to the real world. And it turns out that altered states of consciousness are prevalent everywhere in the hospital. And then we saw a huge rise because of things like inflammation in the brain and delirium due to COVID. And so now I'm taking some of these algorithms and artificial intelligence to a 24/7 remote brain monitoring platform to detect delirium before it becomes a problem. Other places that these kinds of algorithms have been used, other types of altered consciousness, include psychedelics. And we're finding that if you actually map brains that are, say, under the influence of LSD or psilocybin, DMT, ketamine, things like complexity, functional connectivity, information calculating capacity, these all change, just like they do. And the interesting thing is that unlike my anesthetic drugs, where I tend to decrease complexity, decrease functional connectivity, and decrease information calculation capacity, what do psychedelics do you think? They actually increase all of these metrics, almost indicating that brains on psychedelics are maybe more conscious, super conscious. They're definitely more neurally flexible. And Colonel, that same company I showed you before, is combining their flow device with another company to actually look at these kinds of functional changes, for instance, when subjects are using ketamine for therapeutic reasons. But one of the more interesting places for a long time that we've actually seen algorithms being deployed is for movement. Now, how many of you have heard of deep brain stimulation? Great. So for those people who have movement disorders, things like OCD, depression, you can actually implant an electrode deep into their brain, and then you can kind of tunnel the battery pack under their collarbone. And this is the place you can change out the battery, and you can also program different stimuli. And it turns out that many of these devices have different characteristics. Their electrodes are in different places. And this enables them to do things now like closed-loop DBS, where you can actually get behavioral input from the subject. You can read neural activity, and then you can deliver and titrate current into the brain based on these closed-loop systems. And what you can see here in this video is a Parkinson's patient who basically, we're going to start with the stimulator off, and you're going to watch his left hand, and you'll see that it's shaking a lot as he tries to transfer water from one cup to the other. So again, this is the off state. The stimulator is not on, even though the implant is there. And then it's going to get turned on. This feedback loop is going to take place. And just watch him try now with the DBS on to actually transfer water. Same hand. If you want to see a really cool video, go to YouTube and look for the Mayo Clinic and look for a violinist having this operation done awake, and watch him actually play the violin in the operating room. All right, so movement. That was deep brain stimulating electrode. It's actually quite large. They're very thick. This is a different example of electrodes that touch the brain. This is 96 electrodes. This is the most famous brain-machine interface, for those of you who are not aware. It is a Utah array made by BlackRock Technologies. And the smaller version of it is about the size of a baby aspirin. And these electrode arrays sit on parts of the brain, in this case, the premotor cortex or the sensory cortex, and they capture information coming from an individual who may be, for instance, paralyzed, captures their intent to move, and again, deploys artificial intelligence in order to help them move. And it sends this information out to an actuator. Now, this is an older video, and it's important to set this up. This is from the BrainGate Consortium. This woman has one of those implants in her brain. She cannot move from the neck down. And she's using her mind to control this robotic arm to bring a carafe of coffee to her mouth so she can take a drink. It's pretty extraordinary. Now, this is the guy who gets all the hype, right? Elon Musk. So Neuralink, yes, it was founded by Elon, but his co-founders and a lot of his board members are actually people who are from the BrainGate Consortium. And so he didn't invent this technology, but he has made improvements. For instance, because they've got a lot of funding, they can do things like, instead of the sharp metal electrodes, they've been able to create electrode threads with higher packing density, make wireless systems, and make systems that can actually calculate and compute faster. Now, this did not get FDA approval this month to start human clinical trials. By the way, one of the issues that the FDA wanted addressed is what the effect of a lithium-ion battery would be inside someone's brain. The second problem they were concerned about was overheating. So there are a few things to worry about, but they're going to make some progress. Also, electrodes can damage the brain when they touch the brain. And that's why we have non-invasive technologies for decoding and motor. This is a gentleman who is paralyzed from the waist down, but he has an EEG device on his head, and when he imagines he wants to walk, that signal gets decoded by an algorithm, sent to this exoskeleton, and it helps to move his legs forward like this. And by the way, he also trains in virtual reality. We've had a few sessions on that, and we'll have another one. And that feedback actually has enabled some of Miguel Nicolelis's patients to regain neurological function without any surgical intervention. Moving in the non-electric band, that is something that also senses the intention to move, say by an amputee, and these muscle activations are picked up by the band and sent to a bionic arm. And then a few years ago, I was at Augmented World Expo in Silicon Valley, and I saw this device. It's from a company in Israel. It's a band that doesn't measure muscle activations. It measures the intention to move using neural activations. And what they've done is they've moved it into the consumer space. You can see somebody having attached the Moodle device to an Apple Watch to actually turn it into a gesture controller. So this device is now training specifically on these different movements. Let's move on to vision. Reconstructing visual experiences. This is also an older video, but there's a reason I'm showing it to you. One, it's the first example of using algorithms to read the mind during vision. The second is, take a look at the first author, Shinji Nishimoto. He is the postdoc who did this work in Jack Gallant's lab at UC Berkeley. And the work essentially involves putting a bunch of students into a scanner, an fMRI machine, and presenting YouTube video clips to them, recording activity from the back of their brains, and creating a data dictionary. So basically, all the statistics from this first part of the visual system were being compared to the statistics in the images. And by doing this, they were able to reconstruct pretty grossly what that person was seeing. Now, that was in 2011. And in 2013, a group of Japanese scientists in Kyoto tried to do something very similar to map the semantic content of people's dreams. All right, let's fast forward. This is at the end of last year. This is the first example of using generative AI to do this kind of visual decoding. So this is not the study that got a lot of press, but essentially this particular model, you can see the ground truth. Basically, the objects that the subject was looking at are in that column on the left. And the algorithm reconstructed it on the right. That's the thing in red. And you can see that it outperforms any prior algorithm. And the one that hit the press, this is not even a published paper. It's actually going to be presented at a computer vision meeting in 2023. But this is the one that used stable diffusion. And it does a better job than these prior algorithms for a couple of reasons. What you see there is the ground truth on the left-hand side. That's the image that the person was presented with. What's in the Z column is that exact part of the brain that was being imaged in Jack Gallant's study, so area V1. So it's the first part, and you can see it kind of generally captures color and the position of objects, but it doesn't do a very good job in reconstructing exactly what the object was. C, higher visual area, like further in the visual stream. Parts of our visual stream are associated with semantics, the sense of what it is we are seeing. That is where the latent diffusion model comes in, because what it's good at is converting text to image. Has anybody played with these, like DALL-E or, right, exactly. All you do is you give it a text prompt and it generates images. And the end result, when you combine these two things, is something that looks a lot more like what the subject was presented with. Again, on the extreme left, on the extreme right. Now, this has been taken into speech as well to create assistive devices for people who have lost the ability to communicate. Some of the very first studies use that same Black Rock, Utah array in the motor cortex so that people who could not speak but could imagine typing using a mouse could imagine typing out sentences. Since that time, so in 2019 at UCSF, a group in Ed Chang's lab, he basically started his life as a functional neurosurgeon, which meant that he would often do surgeries to remove areas that were doing things like causing seizures. And because he had these electrode arrays over the brain to map the areas of seizure focus, he decided to start doing some recordings. And in one case, he wanted to see if he could reconstruct what somebody was imagining speaking by having them imagine moving their mouths, or to move their mouths as if they were saying something but with no sound coming out. And you can see that reconstruction here. So this is actually motor to speech, and that is the vocal apparatus creating some kind of sound. There's sound on this one.
Is not available in books. The proof that you're seeing is available in books.
That was synthesized by imagining the person's mouth moving. Again, in 2021, a step forward was made where a person who needed to communicate could imagine writing out what they wanted to say, and that was reproduced in synthesized speech. And this was one of the fastest demonstrations yet, up to 90 characters per minute. And again, another company, this time Paradromics, they've kind of beaten Neuralink to these sort of large-scale cortical recordings, and one of their very first clinical uses will be as an assistive communication device. So let's move to hearing. I don't know how many people know this, but the very first brain-machine interface was a cochlear implant. And when we would screen infants and newborns to see whether or not they could hear, if they couldn't, we would immediately try to get a cochlear implant into them because of the plasticity of the brain. Well, that has also gotten more and more sophisticated. This is research that was just published the end of last year by Meta. And Meta has their own AI division. And the reason this is so interesting is because a lot of what I have shown you is using sophisticated algorithms to decode what the brain is thinking, intending, wanting to do when electrodes touch the brain. This was done non-invasively. This was done with electroencephalography and magnetoencephalography. And what they found is that they basically had subjects listening to audiobooks, and they were able to reconstruct using the magnetoencephalogram. They were able to correctly predict the sounds that they were hearing 73% of the time. So that's very unusual. And again, non-invasive, this opens up an entirely new world of possibilities. And just a month later, this was actually, whoops, that has a video. Are you able to help me play the video? This comes out of the University of Texas at Austin, and Jerry Tang's the first author. And essentially what they did was they had people either imagine speaking or watching silent movies, and they tried to reconstruct what it was that they were imagining hearing. And they didn't always get it right, but they did get kind of close, you know, neck, breathing under control. So we're getting a little bit closer and closer to this. And this brings me to what Daniel mentioned yesterday, Amara's law, right? So human expectations, very linear. And right now, we're kind of overestimating. There's a lot of hype about what these devices can do. But with the direction that our algorithms are going in, we will soon be able to non-invasively do so much more than we ever thought. You saw an example also yesterday with Andrew Hessel of DishBrain. This is the chip that is both in silico, but it also has nerve cells that are grown on top of it. And it learns how to play Pong. What he might not have mentioned to you yesterday is that this combination of silicon and neural tissue outperforms artificial intelligence by a lot. It only took this 15 iterations to learn how to play Pong against an AI, something like over 300 attempts. All right, so it's doing really well. All of this is to bring us to the point of understanding something very, very important. These devices have so much promise, but things like these myoelectric bands, et cetera, they're being used by companies potentially to gather a lot of data, to move us into worlds that are full of gaming and places where you might actually be able to, say, use a device like this and read someone's mind and gestures. Now, this company, Neurable, tried to create a mind-controlled VR gaming device. They didn't succeed, but this collaboration did. Galea is a collaboration between OpenBCI, for those of you who have heard, it's a DIY BCI company, Valve, which is a gaming platform, and Tobii, which is an eye-tracking platform. And essentially, what they're trying to do is capture all this biometric data so you can easily move through a virtual space without ever having to touch a controller. And this brings us to this place of neurocapitalism where information can be presented to you and read using algorithms from your face, from your brains, by tracking your eyes, often without consent, often without knowledge. Facial recognition is being added to this, and yes, we can do it with brainwaves. Imagine if you go to get a job, and they actually want to measure your brainwaves in order to know whether or not you might have, say, some kind of neurological disability, or if they might want to know if you have the potential for addiction. And this is where I think that we're getting into sort of this science fiction realm. So I want to also let you know that if you imagine typing in a password, that can actually be picked up and hacked by a non-invasive brain-machine device. We can also create fingerprints using your brain, so brain prints, that can detect your brain with 100% accuracy, completely non-invasive. We have troves of data that can actually analyze using non-invasive data what your mental predispositions might be, and we can digitally twin you, or we can deep fake you. We've also figured out that anything implanted, whether it is a Medtronic pacemaker, whether it is an insulin pump, or a deep brain stimulating electrode, can also be hacked from the outside. And cybersecurity is becoming a huge part of this entire brain-machine interface market. Finally, we have actually learned a little bit about how to create false memories and potentially implant them through stimulation because we've been able to decode what's going on. And this is where I want to leave you with this idea that protecting people's both genomic rights, as Jamie was talking about yesterday, and their neural rights is a really important thing. I was just down in Chile. I don't know how many of you know this, but Chile is the first country in the world that has actually passed a law protecting people's autonomy and agency so that their brains cannot be read from or written to without their consent. So with that, I will leave you. Thank you so much for your attention.
Thank you, thank you, thank you.
Oh.
Mind-blowing. Super, you are mostly on reading the brain. What's your quick synthesis of where we might be in a decade writing to the brain?
Writing to the brain is easier to do when you have invasive electrodes, right? However, we are finding more and more that you can use things like focused ultrasound and even transcranial electrical and magnetical stimulation to get to deeper brain structures. And I think that now that we've been able to decode so much, we'll actually be able to start rewiring nervous systems, especially for mental illness and things of that nature.
Right.
So.
All right, thank you, Divya. Whoa. Some of us still have neurocognitive lapses. If you find a MacBook Pro out in the audience somewhere, I lost it and I can't remember where. So please turn it into the front desk. My BCI is not working very well today. So one of the really fun things about NextMed Health is I just invite my friends, and they're all amazing, and they show up and are incredible faculty like Divya. But next is an old friend, David Eagleman, who's a neuroscientist extraordinaire. You might have seen him on the PBS series The Brain. He's a Pulitzer Prize nominated author. His last book is Livewire. He's the CEO of a really interesting company called Neuroscience. He's on faculty at Stanford, a good friend and colleague, and big brain in the world of neuroscience. Welcome, David Eagleman.
Awesome. Thank you, Daniel. All right. Well, it's so terrific to be here, and thank you, Daniel, for everything you're doing here. Okay, so what I want to talk about today is about perception and how limited we are in what we're seeing in the world. So, you know, we're built out of very small stuff, and we're embedded in a very large cosmos, but we're not particularly good at seeing reality, understanding reality, either of those scales, because instead we've evolved at this intermediate scale with, you know, mates and rabbits and apples and rivers and whatever, and that's where we perceive our reality. But the thing that I want to tell you about as a starting point is that we're not particularly good at perceiving reality even there. There's so much of the world we don't see. So take as an example the colors of our world. You open your eyes and there's all the colors. But in fact, what we're seeing, many of you probably know, is less than a 10 trillionth of the light that's out there. So you've got radio waves and microwaves and X-rays and gamma rays. This is all passing through your body, and it's totally invisible to you. You don't see it because you don't have specialized receptors to pick up on it. So you've got thousands of cell phone conversations passing right through you, and you don't see that. Now, it's not that this stuff is inherently unseeable. So snakes pick up on information in the infrared range, and honeybees pick up on information in the ultraviolet range. It's just that you can't see any of this, at least not yet. So what this leads to, I think, is this very counterintuitive starting point, which is that your reality is actually constrained by your biology. And so what's interesting is that when you look across the animal kingdom, you find that different animals are picking up on different parts of reality. So in the world of the blind and deaf tick, it just picks up on temperature and butyric acid. That's all it's picking up on. It's sensory apparatus. For the black ghost knifefish, it's picking up on perturbations in electrical fields. That's all it can see. For the blind echolocating bat, it's just picking up on air compression waves. And that's how it builds its world. And we have a word for this in science. For this part of the world that you're picking up on, it's called the Umwelt, which is the German word for the surrounding world. And presumably, every animal thinks that its Umwelt is the entire world out there. Because why would you stop to ever think that there's something beyond what you can sense? So let's do a quick consciousness raiser on this. So imagine that you are a bloodhound dog, and you've got this enormous snout with 200 million scent receptors in it. And your whole world is about smell, and you've got these wet nostrils to attract and trap scent molecules. You've got slits in the nostrils, take big nosefuls of air. You've got floppy ears to kick up scent. Everything is about smell for you. So one day, you stop in your tracks, and you look at your human master, and you think, what is it like to have the pitiful little nose of a human? Like, how could you not know that there's a cat 100 yards away, or that your best friend was on this spot 6 hours ago? Because we are trapped in our Umwelt, we never stop to think about what our Umwelt could be. And so my interest as a neuroscientist is to figure out how our technology and technology that we can build will expand our reality. So as many of you surely know, we're quite good at marrying our technology to our biology. So there are hundreds of thousands of people walking around with artificial hearing and artificial vision. And the way this works is you take a little digital microphone, you slip an electrode strip into the inner ear, or you take a digital camera, you plug an electrode grid into the back of the eye. The interesting part is that as recently as about 30 years ago, a lot of people thought that these technologies would never work. And the reason is that these are speaking the language of Silicon Valley with zeros and ones, which is slightly different than the natural biological dialect that these normally come with. But it turns out it didn't matter. It turns out your brain can figure that out just fine. Now, how do we understand that? Well, the secret, of course, is that you're not directly hearing or seeing any of what's going on around here. Your brain is locked in silence and darkness, and all it has are these electrical and chemical signals, and that's all your brain has. But what brains are really good at doing is extracting patterns and eventually assigning meaning to that, and eventually building this, your full, rich cosmos, even though all you have are these different data cables coming into the darkness here. So the point I want to make is that your brain doesn't actually know, and it doesn't care where the information comes from. As long as the information gets there, your brain will figure out what to do with it. And this is a remarkable sort of general compute device, which says, okay, just give me whatever, and I will figure out how to optimally act on that. And so I call this the pH model of evolution. I don't want to get too technical, but pH stands for potato head. And the idea is that you just plug in whatever peripheral sensors you want, and the brain will figure out what to do with them and how to operate with them. So when you look across the animal kingdom, you find all kinds of weird peripheral sensors. You find, snakes have heat pits. That's how they pick up on the infrared. And the black ghost knifefish has electroreceptors all up and down its body. And the star-nosed mole has this weird nose with 22 fingers on it by which it constructs a 3D model of its dark tunnels. And birds and cows and lots of insects have the ability to detect the magnetic field of the Earth and navigate that way. These are all information sources that you can use and pick up on, and the brain will figure it out. My assertion is that once the principles of brain operation have been established by Mother Nature, she doesn't need to reinvent the brain every time. All she needs to do is tweak the genetics to build different sorts of sensors that are picking up on different kinds of information, and the brain will figure it out. And so the lesson that surfaces here is that eyes and ears and nose and all these things we're used to, this is just what we happen to have inherited from a long road of evolution. But it's not what we have to stick with. And our best proof of principle for that comes from what's called sensory substitution, which is where you feed information into the brain via unusual pathways, and the brain can figure it out, can figure out what to do with it. Now, that might sound speculative, but the first demonstration of this was in the journal Nature in 1969, where a scientist named Paul Bacchi-Rita put blind people in a modified dental chair, and there's this solenoid grid that pokes into their back. And so he set up a video camera, and he put something in front of the camera, and whatever is in front of the camera, you feel that poked into your back. So whether that's a triangle or a face or a circle or whatever, you feel that poked into your back. And blind people got really good at being able to tell what was in front of them visually just based on what they were feeling in the skin of their back, which is wild, right? And there are many different incarnations of this. So one of them is called the sonic glasses, where for blind people you have a camera, and whatever is being seen visually by the camera gets turned into an auditory stream. So it's, and blind people can get so good at this sort of thing that they can, learn how to navigate a complex obstacle course, things like that. And it doesn't have to be the ears. There was a group that did this with an electrotactile grid on the forehead. Why the forehead? Because you're not really using it for anything else. The most modern incarnation is an electrotactile grid that sits on the tongue. And so whatever the camera is seeing, you feel that on your tongue, these little shocks. It kind of feels like pop rocks in your mouth. And blind people get so good at this, they can do things like, throw a ball into a basket at a distance and actually operate this way. Now, if it seems completely crazy that you could come to, see through your tongue, just remember that it's equally bizarre that you come to see through these two spheres embedded in your skull that, convert photons into electrical patterns. It's the same kind of thing. Whatever the brain receives, it just figures out what to do with it. So one of the goals of my lab was to see if we could build sensory substitution for people who are deaf, so that something gets said and someone who's deaf understands what was said in the auditory world. And so we ended up building a vest that has vibratory motors in it, and it captures sound and turns the sound into patterns of vibration from low to high frequency. It breaks it up, which is exactly what your inner ear does. So I presented this at TED some years ago. Here's what it. So as I'm speaking, the sound is getting translated into dynamic patterns of vibration. I'm feeling the sonic world around me. So if you look here, you can sort of see how it looks. So on the left, she's saying the word sound. You can see it goes sound, and it's a touch. And you can see the different patterns. It's like being able to see what the inner ear is doing. Anyway, so she feels that on her skin. So we started testing this many years ago now. This was our very first participant, a gentleman named Jonathan, who was born profoundly deaf, which means there's a part of his umwelt that was unavailable to him. So we had him train with the vest a couple hours a day for 4 days. Here he is on his 5th day. This is my graduate student, Scott, on the right. So Scott will say a word. You. He says the word you. And then Jonathan feels his pattern of vibration and writes on the board what he thinks he's felt there. Where. So Scott says where. And Jonathan, translates this complicated pattern of vibrations on his vest into an understanding. Touch. Scott says touch. So, Jonathan's not doing this consciously because the patterns are too complicated. In exactly the same way that you're not using your cochlea consciously. You're not thinking, oh, Eagleman's saying some high and some low and some medium frequencies. You feel like you hear me. And that's exactly what happens here. So this was a gentleman that we had at our offices a little bit ago. National Geographic was out to film, but it wasn't because of him. It was because of his daughter, who was born deaf and blind. So we built a little miniature vest for her, and it's picking up on sound. So this was the first time she was able to hear the sounds of the world this way, to pick up on that. So here her grandmother is taking her around and touching her feet to things and saying, this is soft, this is hard, and so on. And on the right, it's a bed that's going up and down. So the grandmother is saying up, 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 down, down, down. And this is, of course, how you learn how to use your ears in the world, is by making correlations with other senses. That's how you figure it out. So in the interim, what we did is we shrunk this down to a wristband, which is what I'm wearing here. So the wristband is picking up on sounds, and it is a much more convenient form factor. And we're now on, wrists all over the world. This was, by the way, our very first participant some years ago, a gentleman named Philip, who was trying to say, I'll just show this to you for a second so you get a sense of what it's like when you suddenly tap into the world of sound that you hadn't had before. So we're on wrists all over the world, and this is just a word cloud of things that people reported to us, of sounds they picked up on that in their being deaf, they had not known that these were sounds that were going on around them, and so it's been a really lovely thing to experience this. And so I just want to mention, one of the reasons this is important is because the only other option for somebody who's deaf is a cochlear implant, which is $100,000 and an invasive surgery. And our thing is, 100 times less expensive, and that's why we're all around the world and in deaf schools, things like that. So I just want to mention we have a couple of new things going on now. It turns out that what we have now is the best solution on the market for tinnitus, ringing in the ears. And the way this works is something called bimodal stimulation, where you play sounds around somebody's frequency of tinnitus, beep, the ring in the ears, and you're feeling the corresponding sounds on your wrist. And it turns out that works super well for driving down tinnitus. And essentially it's because there's some very sophisticated arguments for why this works. But essentially I think it's because you're teaching the brain what is a real external sound, because that always gets verification on the wrist, versus beep, beep, which is fake news. And so the brain realizes, oh, that doesn't get any confirmation, and so it drives that down. So that works very well. We've recently been publishing on that. And then the latest thing, which we just released, is a replacement for hearing aids. And the way it works is this listens in real time just for high-frequency phonemes, just the high-frequency parts of speech. And it buzzes and tells you, oh, I just heard an S. Oh, I heard an F. I heard a TH, things like that. And so what happens is a person's ear, as people age, they get high-frequency hearing loss. The high frequencies is what they lose. So their ears are working fine at the medium and low frequencies, and this just picks up what's going on at the high frequencies, and your brain learns in about a week or two to fuse these signals. And so what we find is that the feedback people give on these subjective tests is better than hearing aids. And by the way, it doesn't have the social stigma that a lot of people worry about with wearing hearing aids, because it just looks like a Fitbit. We're running experiments now at Stanford and at Wake Forest with balance. So we just built a little collar clip. And so if somebody has a balance problem and they tilt and they get off axis, we have a 9-axis motion detector in there, it talks to the wristband, and so you know which direction and by how much you're tilting. So we're running those tests now. We've also been doing this with prosthetics. So it turns out that when people get a prosthetic leg, they have a hard time learning how to walk because they don't get any feeling from it. And so what we did is we hooked pressure and angle sensors into the prosthetic, and we feed that into the vest or the wristband. And so somebody with a prosthetic can feel what their new leg is telling them, just like you feel with your normal leg. And so that works super well in terms of giving someone immediate feedback about that. So we've got 70 different projects going on in the lab. One of them is, with robotic surgery, instead of having to monitor, look at all the monitors all the time, just being able to feel what's going on with the patient's vitals, being able to feel that while you're doing the surgery is one thing we're doing. We are doing things with artificial smell. So instead of needing a dog to do the smelling for you, you can have artificial molecular detectors that take care of this and feed you all these smells, and you just feel it. And we've actually got lots of other projects going on in terms of, feeling real-time streams of data from the internet, or feeling a drone when you're flying it around, and so on. But I just want to zoom in on one thing, which is feeling the spatial extent around you. So one of the things we're doing for the military now is reducing friendly fire, where you can feel where your colleagues are around you, even if you can't see them. So I can feel, okay, yeah, Bob's over there, and Tim's on the other side of that wall over there, and whatever, even though I can't see them. So this reduces the possibility of accidents of shooting your own forces. And so it just so happens that I'm there was until this went out, but I was a scientific advisor for Westworld. And so one of the things I did is I put the vest in that show. So now I call it Vest World, which sounds Yiddish, but anyway, I don't know if anyone saw season 2, episode 7, but these guys drop in, so that's the vest. But if you look at the guy in the center here, he's wearing the vest and it's lighting up and so on. But the point is, what he's doing is he's feeling where the bad robots are, the hosts, and so he is able to take care of them accordingly because he can feel their location. And so, this is just a different scene here where they weren't expecting any hosts there, but then they feel it and then they get killed, which goes to show you that if AI goes bad, my vest isn't going to help you at all. But what we did do, though, is take this idea and we use this for people who are blind. So we're using LiDAR to know the location of everything going on in the offices. And this is a blind gentleman who can feel, oh, there's somebody coming up on my left. Oh, they're moving behind me now. What we added on top here, what you're seeing, is we added navigation on top of that so that it says, OK, go straight. Oh, now turn left. Oh, now go to the right. And by the way, what we're doing here is steering him to a 45-degree conference room and seeing if he can, do that, which he can easily find, and so on. So anyway, this is part of what we're doing. So I just want to wrap by saying there's really no end in sight in terms of the kind of senses you can add. So one thing I want you guys to do is think about what would be things that you would want to add, being able to detect the state of your microbiome, or feel your blood pressure, or feel something about your EEG, or states of our body that are normally totally invisible to us. can be detected and perceived. And so the bottom line is we don't really have to wait for Mother Nature anymore in terms of, for her sensory gifts on her timescales, because what she's given us, like any good parent, is the cognitive ability to go out there and define our own trajectory. And so the question for us all to think about is, how do you want to experience your universe? Thank you very much.
Incredible work. How long does it take to rewire your brain using some of these things and other technologies that can accelerate that?
Yeah, well, so when it comes to spatial extent, like for the blind people, it's instant. So that's something that we just have an immediate sense of. Other things like learning to hear takes a few weeks. And as far as technologies to accelerate it, there are all kinds of possibilities for things that increase plasticity, like transcranial magnetic stimulation. We haven't tried those in combination yet, but I think that's the next step for us.
And sometimes it means ultrasound can now provide sense. Can it be built into our cars, into our car seats, other environments to give you sensing?
Yeah, exactly. We've actually built car seats for Toyota now, where you can feel, there's silly stuff like you feel the radio broken up into all its frequencies, which is super cool. And in fact, when people turn off the seat, they say the music feels thin after that. But it can also tell you lots of other things, like there's somebody coming up in your blind spot, and you can feel them coming up, and you can feel where the rest of the traffic is.
So next year's Sacred Cacao ceremony, we're going to integrate this technology, and it'll get even more trippy.
Excellent.
All right, thank you, Daniel.
All right, thanks, Daniel.
All right. So our last little section on neuroscience in the brain, which could, again, span all 4 days, is my friend Ariel Garten. She's the CEO, founding CEO and co-founder of Interaxon Muse. And you're going to hear about where that's gone over the last decade and where it might go into the next. Ariel.
Hello, it's awesome to be here at NextMed. I'm here to talk about low-cost EEG sensors. So we've just all heard about how sensing is transforming healthcare. I'm here to specifically talk about EEG sensing and how it can democratize access to the brain in interesting ways. Now, in the past, we know if you wanted to get a brain scan, you'd go into a hospital and have a machine like this. Now, we have devices like this that very sleekly and easily track your brain in your own home. Now, Daniel is very prescient. He invited me to be on stage right here in 2013, a decade ago. He saw that I was doing low-cost EEG. He said, come on in and tell my audience what it's going to be. Now, this was before the first Muse was even in market. The first Muse launched in 2014, and in the past decade, Daniel was right. Low-cost EEG sensing is here, and it has transformed healthcare across a variety of different applications. I'm going to tell you about what's now and what's next for just a few of them. Now, in 2013, if I told you that the killer app for low-cost EEG sensing was going to be meditation, you'd probably think I was crazy, like many VCs we told at the time who now use Muse to meditate. And since then, 500,000 people have actually used Muse to start or enhance their meditation practice. And it's actually transformed the way that you can deliver meditation in healthcare. We know that if you have a patient who needs to meditate, you tell them to meditate. They go home and nothing happens. You give them a book, nothing happens. Now you simply hand them a Muse. They go home, they use this very cool gadget that gives them real-time feedback on their brain during meditation, teaches them how to do it, encourages them when they're doing it right, gives them real data, and can send that data back to the clinician. So we now have multiple clinicians many clinicians that recommend Muse across a variety of conditions like anxiety, pain, OCD, and more. We have multiple trials going in these different conditions. And we find Muse used by the healthcare staff themselves to help manage burnout. When we peer into the future, we're creating actually customized programs for different healthcare conditions like menopause, pain, depression. And we're also seeing that in the near future, the medical application of meditation is growing. And ultimately, this may be a standard of care across multiple conditions. So when you think about having a clinical-grade EEG that can track your brain in a really comfy way in your own home, another great application is sleep. We came out with the Muse S, which you can wear during sleep, and it's actually able to track sleep essentially as effectively as a sleep lab. So instead of going into a hospital with tons of wires on your head, you can simply sleep in your bed and get sleep lab quality data. As a consumer, this is awesome because you can finally get real EEG data during sleep. You can see your deep sleep, the depth of deep sleep, the microstructures of sleep. And in healthcare, this is quite transformative because instead of $3,000 a night for a sleep study with a bunch of wires in a strange bed, you can now have patients and subjects do sleep studies in their own home for $300 a night for as many nights as needed. We're currently doing a number of large-scale studies, one 1,500-person study with the Canadian Centre for Neurodegeneration and Aging, looking at their population and how they sleep. And we're, with our research partners, doing a number of broad-scale population-based studies looking at cohorts of people like people in depression, marginalized economic status, and looking at their EEG sleep data and able to look at that on a very, very large scale and see the kind of data you wouldn't otherwise gain access to. So now once you have a comfortable sleep product in somebody's bed tracking their sleep, you can easily give them interventions for sleep. We came up with something called the digital sleeping pill that is now in popular consumer use. What it does is it tracks your brain while you sleep and then gives you responsive audio feedback based on your own biodata that helps you fall asleep faster or fall back asleep if you've woken up in the middle of the night. This turns out to be quite effective. It's been demonstrated to improve sleep quality by 20%, including improving the amount of time it takes you to fall asleep and fall back asleep. When we look at what's next, now that we can deliver content while somebody's sleeping in a responsive manner, that means that you can also create suites of lucid dreaming tools to deliver a precise sound at the moment when somebody is in REM sleep. Or you can use it to do research and query states of consciousness as somebody moves from one state to another. So another cutting-edge healthcare technology we've heard all about at this conference is VR. And of course, you can take VR one step further when you integrate brain and biodata with your VR system. What's next? Well, we're coming to market with our VR Muse integration. If anybody's interested in a prototype, come chat with me. So when you have somebody who is sleeping or meditating or VRing with an EEG headset on, at the same time, with their permission, you can gather data, vast quantities of data. So we have amazing quantities of both longitudinal data. We have some people who've used Muse to meditate for every single day for the last 4 years or more, as well as large population spread data. And that's allowed our partners to query for some really interesting biomarkers. We found biomarkers for brain aging. Our partners have found biomarkers to detect stroke, age-related cognitive decline, psychedelic states, and more. And of course, what does this all wrap up into when you're able to precisely determine somebody's state, have a biomarker, offer an intervention? What we're talking about is precision medicine. The ability to determine where a person is at, what they and their brain need just at that moment, and deliver a personalized intervention right at the moment when it solves them best. So we're excited to be exploring all of these areas with our partners and happy to chat with anybody about sleep, Muse, EEG, meditation, and more. Come find me and we can chat.
Thanks so much. And we did a fun little competition on headlines from the future before NextMed. We have our winner here, Philip Edgecombe, a MD, PhD resident in radiology. Stand up, Philip. So my challenge for all of you is to tweet out your headline from the future, and the 2 top winners will win a Muse headset. So get on Twitter, use social media. The hashtag is #NextMedHealth, and the Twitter handle is @NextMedHealth. So let's hear your headlines from the future, folks online and in the room. Okay, so before we go to our lunch break, we have a really cool session about, I think, integrating these technologies in the health systems of today and the near future. And leading off and helping us moderate the session is our long-term faculty, John Madison. I think he's been to at least 10 of our prior programs. He was the Chief Medical Information Officer for Kaiser Permanente, put in their first EMRs, drove a lot of innovation at scale, also their Assistant Chief Medical Officer. And he's going to open up this session with Ron Ballister and Rasu Shrestha, looking at the future of health systems and beyond. John.
Thanks so much, Daniel. And I love challenging topics to talk about. And when Daniel asked me a while back, say, can you talk about the future of hospitals? I thought, well, that's pretty challenging because they're the biggest dinosaur in an obsolete healthcare delivery system. And then, so I prepared my comments to really address some of the headwinds for the hospital as the center of the healthcare system as it has been historically. And then just a few hours ago, we found out that the panelist who was most connected with the hospital of today is out ill today and won't be able to come. So we recruited Ron, who you've already heard speak from Khalid in Israel, to join the panel. And so what we've discovered is all three of us are huge advocates for the hospital at home and have very little optimism about the role of the hospital in the future. So we're going to be transforming the discussion into more of a view of how everything you've heard about at this conference so far and for the rest of the conference in digital health is going to move more and more and more of what happens in the hospital to the home, in the hospital home construct. So I'd like to start off with a couple of quotes from some of my favorite quotable writers. So William Gibson famously said, "The future is already here, it's just not evenly distributed." And I like to add, converged, operationalized, and scaled. So innovation is actually easy compared to the convergence of technologies, the integration with workflow, and the scaling of those systems up. The second one is from H.L. Mencken, who famously said that for every large, complex problem, there's almost always at least one simple solution, and it's usually wrong. And then the third quote is from Charles Dickens in his introduction to Tale of Two Cities, and it's the best of times and the worst of times. It is the best of times for digital health and moving healthcare into the outpatient environment, into the home, and making it much more person-centric than it has ever been in the past. So if you put all those things together, I think you arrive at the conclusion that the way to think about the hospital of the future is what's left after we migrate from a sick care system into a true healthcare system augmented by digital health in the outpatient environment. So the U.S. healthcare system has been described by broken as just about everybody, including myself. But a friend recently pointed out to me that, in fact, it's not broken. It's working as designed. It's designed with incentives that are totally and utterly ineffective, counterproductive, and outdated. So we have a regulatory system, we have a reimbursement system embodied in the fee-for-service model still in this country that incentivize doing stuff rather than creating health. And so what we're all about in this digital health world is how do we move that incentive system. And so why is the uptake of digital health occurring so slowly? What is the problem there? And probably the biggest, I asked David Ewing Duncan to review my speaker notes and give me any thoughts, and he basically said that it really is much easier to innovate than it is to try and change the framework and the incentive system that has been the largest impediment to the adoption of digital healthcare. So in addition to that, we have a lot of headwinds. So I'm going to be Debbie Downer for just a moment here. We've got a rising population and longevity. We have a dramatic rise in anxiety and depression as a consequence of the pandemic, and the behavioral health issues in young children is really frightening. At the moment, suicide rates going through the roof. We have soaring rates of our most vulnerable population that is unhoused. We have the Great Resignation that landed on top of a massive burnout of healthcare workers across the U.S. and many other countries, the UK being no exception. We have rising morbidity in the aftermath of COVID. So all of our public health policy has been based upon how do we take care of acute COVID, when in fact the long tail of the COVID pandemic manifests not just as long COVID, affecting tens of millions of people in this country and far more globally, is also attended by a much higher risk of neurologic, psychiatric, cardiovascular, and other long-term conditions. The VA published a study showing that the highest risk factor for new onset of cardiac disease in their population, so it's population specific, but in the population of U.S. veterans, the #1 risk factor for heart disease now is a prior history of acute COVID. And these long tails of COVID are going to present a persistent, significant increase in demand for healthcare services at the time we're experiencing the Great Resignation and burnout in our healthcare systems, particularly in hospitals where nurses and physicians are bailing on the system itself. So how do we rethink the role of hospitals and the hospital at home movement in ways that address this growing impedance mismatch between the rising demand on healthcare services and the declining supply of healthcare workers? How do we use a human-centered design approach to thinking about these problems? And how do we apply empathy and compassion in our design, in a human-centered design approach, to address this growing gap between demand and supply in healthcare? What are the implications for hospitals? How do we address these systematic headwinds that I mentioned earlier? So the clock is ticking. And fortunately, our two panelists are both at the forefront of bringing digital health and addressing some of these imbalances by leveraging digital technology to narrow the gap between supply and demand. So I'd like to bring out our two panelists now, if we could. If you don't mind coming out, Ron and Rashu. Great. Go ahead and have a seat.
Thank you, thank you.
And so, Ron, you've heard from this morning already from Khalid in Israel, one of the true leaders in digital transformation, and you heard how well they managed the public health policy associated with COVID that we did not do nearly as good a job in this country, and most countries did not do as well as Israel. So a shining example of how to apply technology to a very novel, complex threat to the healthcare system. Razu is a physician, innovator, informatics, strategic leader of numerous health systems, and just announced last week that the health system he's working with has a deep collaboration now with Best Buy for bringing a lot of these digital healthcare services into play. So he's going to give a presentation, and then we're going to have a discussion, and I've encouraged both of them to please find a way to disagree with each other. And they both responded by saying, I don't agree with that. I think we should agree on everything. Both of them independently. So anyhow, Razi, take it away.
All right, thank you. Appreciate it. How are you all doing? All right, let's cue the slides. So this is just pre-lunch. So food for thought is what I'm sharing with you as an appetizer for the amazing lunch that we're all going to have. I always enjoy coming and speaking here, and I think the conversation that we're going to have on the stage is going to be quite remarkable. I'm going to talk about ecosystems. Our new job description today is that we are curators of ecosystems, or Plecosystem. We'll talk a little bit about that as well. So that is the pearl, and we'll talk more about it. But it is about innovation and strategy in action. How do we not just come up with brilliant ideas, but how do we put them into action, right? How do we create the impact that we need to be creating across the board? It is about the now, it is about the near, and it is about the next. It is about creating impact now, making sure that we're able to take all of the all of the elements of the technologies, the capabilities, as well as then the empathy that we're talking about, and putting it into the redesign of the health systems through the view of innovation. So what's really interesting is we're now entering into the 4th year of this global pandemic that we're in the midst of. Even just saying that out loud gives me shivers, right? And I love this quote by Gregory Williams, and he says, "On the other side of a storm is the strength that comes from having navigated through it." So how are we going to innovate differently? How are those care models that John talked about going to be different? How do we learn from all of the great things that have happened in Israel? And how do we make sure that we're able to democratize that globally? I think leadership has a big role to play in that, right? And amidst the chaos and the uncertainty that exists out there, I believe that the role for leadership is actually to provide clarity. It is not to provide certainty. Right? And so there are a couple of lessons learned that I thought I'd quickly summarize here, and this is stuff that we've been talking about. We're one global community, and that is so apparent in the conference here. The walls between medicine and public health have really come down, right? And that's wonderful. The walls between health sciences and life sciences, as we're talking about here at NextMed Health, have really come down as well. Fee-for-service has failed the test of the pandemic. It's not working, guys. It really isn't. And then last but not least, cloud, virtual, artificial intelligence, ChatGPT, all of the buzzwords that we set aside previously as just buzzwords, well, these are not just aspirational elements anymore. These are must-have foundational cores to reinventing what health and care should be all about. So last year I went live with what we call Impact 2025. This is a 4 or 5 year strategic plan for our health system. And really me and the team, we had a lot of fun building all of this together. But when you think about all of the elements of the opportunities that the crisis presented to us of the pandemic, we had to think really deeply in terms of, all right, what does it mean to create a 5-year strategic plan? And the vision really that was, we said, all right, we're going to be the leader in health, learning, and community. Think about that, the trifecta of not sick care, but really health. Not even health care, but health, learning, and community. Ron earlier talked about the learning health system. We are one of the largest learning health systems in the United States, and I'll talk a little bit more about that. But community, how do we make sure that we're able to really bring in and uplift the communities that we're a part of? So big news, fall of last year, the FTC finally gave us the thumbs up, and we merged with the Advocate Aurora Health System. So we being Atrium Health, which is headquartered out of Charlotte, we're now part of Advocate Health. That's the new name for our large health system. And we're pretty big, right? Maybe we can have a conversation about, bigness. But we're about 67 hospitals now, both across the Southeast and the Midwest, about 28 billion, close to $30 billion in annual revenue, and that's pretty large. But really, it's less about the big, it's more about the bigness of the impact that we can create. How do we do more? How do we do better? And how do we do it faster? I think that's really, really critical. So we made public pledges, and these are 6 pledges that we've made, and I won't go through each one of these, but clinical preeminence and safety, really important as you think about health system transformation and innovation. Health equity, again, on this side of the pandemic, with all of the lessons that have been taught to us. Affordability, next generation workforce, John, to your point earlier. Learning and discovery and innovation, and how do we make sure that we accelerate the pace of that? And then environmental sustainability, really critical as we think about how we reinvent the future of health and care. So, healthcare is broken. Yes, it is all about sick care. That's the reality of the economics of the health system and how we are delivering care today. But really, if we broaden that aperture, it's about preventative care. But I'd say let's broaden it further into well care, right? That's really, really important. But I think if you broaden it out a little bit more, it really is about how do you live your best life? And that's what this argument is really about, okay? It is about moments that matter. And we all have these moments that matter, and that's what this is about. It is not us going to a hospital and someone asking you, hey, what's the matter with you? It's about what matters to you, right? It's making sure that we're able to study the entirety of that continuum for that human being, for that person, not just the patient. The patient will always remain in the center of that equation, but really broadening that aperture and looking at more of a person-centered approach to care. Because if you apply digital to a process that's broken, you'll essentially at best have a broken digital process. So John talked a little bit about our amazing partnership, and we talk about how care is shifting from the bricks and mortar facilities to where you eat, work, live, and play. Right? Part of the Impact 2025 strategic plan has really been about connected care everywhere. So just a couple of days ago, we announced a groundbreaking partnership between Atrium Health and Best Buy Health, and really excited about this. This is the future of health. And I'm very, very excited about this. I truly believe that the home is where the health is, right? And so when you think about this, and we look at all of the innovations that we pushed forward at Atrium Health, now Advocate, through the pandemic, we created the country's largest hospital home program. These are paramedics, these are social workers, nurses, physicians, remote patient monitoring, digital data, going into patients' homes and caring for them in the comfort of their homes. And we're now growing that program. So think about the Geek Squad evolving into a health tech squad. Think about the intersection of not just technology, but empathy. Human beings going in with technology and meeting our patients, our consumers, where they choose to meet us.
Geek Squad will be setting up more than TVs and computers, like you mentioned. It does that a lot, but the retailer's now struck a deal with North Carolina-based Atrium Health to install medical devices for patients who qualify for hospital-at-home programs. The devices monitor everything from blood pressure to oxygen saturation and respiration rates. The companies didn't disclose the financial details, but said Best Buy will sell healthcare devices, handle installation, and educate patients and their families. The initial goal is to provide care for about 100 patients per day. That's roughly equivalent to a mid-sized hospital.
So think about that. It's equivalent to essentially a mid-sized hospital. And how do we scale this, not just across our system, but really across the globe? So the key to all of this is building ecosystems. One of our lead surgeons says, hey, with the things that we're doing, we're really building something that has never existed on the face of this earth. And I know that's what you're all here for. So the call to action from all of us to all of you is join us in this journey, right? So at Atrium, now Advocate, we're building this innovation district. And we have an innovation district up in Winston-Salem in North Carolina, for those of you know where that is. Innovation Quarter, really brilliant. We've got lots of amazing things. And this is about placemaking. This is not just about innovations and cool ideas. It is about impact. As I was saying earlier, it's about placemaking. We have over 90 companies, 330 acres, 2.1 million square foot of space in Winston-Salem in North Carolina. And 90 minutes away is Charlotte. Charlotte is the headquarters now for Advocate Health. And I believe that Charlotte is ready for an innovation district, right? It is the second largest financial hub in the country after New York City. It is one of the fastest growing cities in North America. And the favorable business climate there allows for us to really come together in terms of the confluence of intersection points. Yesterday there was an amazing talk about storytelling. And when I tell a story about the Pearl, our innovation district, I hearken back to the historical elements of the Pearl district and Brooklyn, and where this was the largest concentration of African Americans in the Carolinas. And with the growth of Charlotte, as I just described, that population was essentially displaced. So we're building the innovation district right in the heart of it, and so we're calling it the Pearl, connecting the past to the present and the future that we're building together. What's really interesting is this, for example, right in the middle of this, the Myers Street High School with what's called the Jacob's Ladder. You see that little ladder there, right? That was the Jacob's Ladder that was in that high school in 1886. I'll come back to that in just a little bit. But the symbolism of the Pearl, right? Growth through disruption. I think that is really significant to the charge that we all have. And I'm connecting the Innovation Quarter to the Innovation District, the Pearl that we're building in Charlotte. And this concept of the ARC, the Innovation Corridor, connecting the innovation districts, not just in the southeast part of the United States, but really imagine arcs going out to other parts of the country and globally as well in this ecosystem that we're building together. Really, really excited about that. So a couple of quick details in terms of the ecosystem that we're building in Charlotte alone. So for those of you who've been to Charlotte, you realize what a beautiful city it is, right? And we also have the Atrium Health Carolinas Medical Center, our flagship hospital. And through the pandemic, we actually acquired over 30 acres of property, of land between Uptown Charlotte and Carolina's Medical Center. So that's what it looks like right now. That's what it's going to look like, 4 million square foot of build out in just the next couple of years. We actually broke ground for this a couple of weeks ago. And it really is a knowledge community, patient-centered research, this connective fabric that promotes those intentional collisions between researchers and clinicians and innovators and investors and community members, this innovation infrastructure that really drives towards inclusive economic development. Over 5,500 jobs will be created just in the Pearl itself, and 11,500 jobs across the county. So this is a big deal in terms of creating this ecosystem with community impacts, youth engagement, accessible jobs. Again, the things that we saw were prioritized on this side of the pandemic, right? How do we make sure that we're inculcating this as we reinvent the future of health and care and health equity and minority and women-owned businesses? So really excited about this. I won't go into too much detail. This is the phase one of the build-out. We have the new medical school. This is the first and the most innovative medical school on this side of the pandemic, and really excited about that. The business school, the School of Professional Studies, and then right in the middle of this as well is, if you can see it, the Jacob's ladder between the two buildings. So very, very excited about how this is going to look like. Some quick snapshots into the inside of the medical school as well as the buildings that we're building. There's the Jacob's ladder that I talked about earlier, again, paying homage to the past as we reinvent the future, right? Bringing in VR and augmented reality and mixed reality and the future of training into the inner workings of how partnerships, Siemens, Stryker, and others, really coming together to reinvent the future of surgical training, experiential learning, and community development. So really excited about this. ERCAD, that is headquartered in Strasbourg, France. They will establish their headquarters in the United States in Charlotte. So really, really excited about that. And we have Stryker, Siemens, and all of these companies coming in and partnering with the ecosystem. So the new medical school, the largest, but also the most innovative on this side of the pandemic, and we're revamping the curriculum, right? Condensing the curriculum, but really inculcating critical thinking, design thinking, as John was mentioning earlier, entrepreneurship and innovation into the curriculum itself. So innovation done right makes technology invisible. Right? Really, our new job description is that we are architects of ecosystems. So with everything that we're talking about today, my challenge to all of you is, how do we make sure that we're able to work together and create that ecosystem that we're talking about and reinvent the future of health and care?
Great. So I'm going to ask a question based upon a couple of your comments and let Ron respond first, and then have you respond after Ron, if that's okay. So you mentioned in leadership it's much more about providing clarity than certainty. So all three of us and many of the people in the audience have a very clear view of what's wrong with the system today. We have a very clear view of what the future will look like when it's fully deployed in the William Gibson frame of the future's already here, it's just not evenly distributed, and my addition of the converged, operationalized, and scaled. So given that we have clarity about where we are today and clarity about where we want to end up, how do we provide some more clarity about the transition where we have all these headwinds hitting us at the very time we're trying to turn the aircraft carrier into a different direction, and a lot of the costs of implementing digital care de novo are front-loaded, and the benefits in preventing health deterioration and hospitalizations and so forth are more backloaded. So how do we provide some clarity about the transition from where we can clearly see we are and where we can see we clearly need to go? So Ron, if you don't mind taking a shot at that first.
Sure. So I think you've hit a lot of nails on the head, and it's a tough one. You know, they say that every system is perfectly built to get the results it gets. And so what you get is what your system is fully designed to do and incentivized to do, and it goes back to that. So if your question is, we know where the journey will end, but where do we start? It's where it is easiest in your system design to be beginning with, where it makes most sense to get the CMO and the CFO to agree on. And many of the things we discussed today, there will be a big fight over those. So you need to figure out what are the domains where it does make sense on that front. And the second thing is, where does your structural strength put you in a position to have early wins that would give you the enough thrust to continue forward. So a lot of systems are trying to really redo all of the basic infrastructure, the digital infrastructures. That's a ton of work, and it takes a lot of time before a patient or a manager in the system feels some of the benefits. So it's really important in our experience at least, to have some quick wins where you can show what matters. And the last point I'll mention is that you need to connect to the organizational strategy. Every organizational strategy is different. They put an emphasis on something else. If you innovate outside of the center of gravity of your organization's key strategy and where the CEO is leading them, well, there's a good chance you'll be stopped midway because the difficulties will definitely be immense.
Great answer. And Danny Kahneman, the Nobel laureate who pioneered behavioral economics, would have been thrilled with that answer. Basically, you said, operate on your strengths, pick the low-lying fruit first. So, Razu, if you could take that and help us understand how, when you've got a clear vision of where there's a huge value proposition for something that doesn't currently represent a strength, that isn't necessarily low-lying fruit, but which will deliver a huge return on investment in the end. How do you incorporate that in your strategic thinking in ways that are not your core strength and not the lowest lying fruit? Because I agree 100% with that strategy, but occasionally these things are sort of compelling that we need to step outside of that comfort zone. How do you think about doing that?
Yes, it's a great question, and I'm really glad that we're having this dialogue today. What's really interesting is we've been incentivized, we being the collective we across the board in healthcare globally, for this mere metric of heads in beds, right? I think all of us believe that if that really is the metric that drives us forward, then we have failed. We have failed miserably. So I think it really is about leadership. I'll bring you into our ELT, our executive leadership team meeting. And as I mentioned earlier, we're in the midst of a massive health system merger. And it's really interesting. We're now the 5th largest health system in the country, maybe 4th, the 2nd largest academic health system in the United States. And the comment I made was, I said, look, my greatest fear is that we forego the opportunity, and I'm sharing this with all of you, that we forego the opportunity for us to really come up with a more forward-leaning operating system, right? An operating model for our health system. And I fear that because we're all here, all of us in this room, because we're really good at what we do, right? I think we need to be confident of that. But the reality is, if we continue to do everything that we're really good at doing in our individual silos, at best, we're going to be massively successful at being massively mediocre. Right? And I think that's horrible.
I want to resonate that further. When we were in the university and we would ask, what's the curriculum for this course? And the usual answer would be, look at the test. The test is the real curriculum. Everything else is cheap talk. I think when we look at the healthcare system that we are at right now and we ask, what's the test? How do you know if you've done well? So if you're in industry and you have a clear financial bottom line, that's pretty clear what you've come to do. And that is the curriculum, no matter what you tell in your syllabus. That is your curriculum. But if we will have a different bottom line that we will all be tested on, that might be different. And I want to challenge everyone who sits here in the audience, and I'll ask, what is the measure or the measures that you want to look at the end of 2023 and ask, are we doing better than 2022? What is health measured? What does that mean that I've done better this year than last year? What have you improved really? And do you have the metrics to genuinely ask yourself if you've done better? And I think most healthcare systems do not possess the system, the will, or the data to ask themselves whether or not they're doing better this year than they've done last year. And what remains is the financial bottom lines and beautiful stories. And so as long as this will be the case, this will be a combination of the financial incentives and narratives. And I think one of the things we need to fix is the measurement system of what comprises good outcomes of a healthcare system, be it a hospital or an integrated care system. And I think that would be really important if we want to really, really transform care.
And that's a fascinating point, you know, because you teach to the test, and your comment that what the test looks like is what the curriculum is. And when I was doing some consulting for the NHS a number of years ago for 3 different primary care trusts, one of the metrics that they used in their test, which is totally foreign concept in this country, is what % of deaths occur at home as a metric of success, rather than the American model of ensuring that everybody takes their last breath in a hospital bed. So maybe one way of restructuring the test, instead of heads in beds, maybe it's heads in beds at home instead. And referring to keeping people healthy and out of the hospital in the first place, in addition to the NHS's metric of having a more dignified and peaceful exit from this life at home rather than hooked up to a ventilator in an ICU.
I love that, right? I think for the longest time, and I'm a physician myself, you know, we've been incentivized, and this is how we're taught, this is how we're wired in the United States, maybe globally. We're incentivized, we're wired to perform heroics. Right, and it shouldn't be about that. I really think it should really be a focus on what is most important to the heart of that person. Right, so let's make sure that we're able to embed all of that. And you know, to Ron's challenge earlier, I would up that and say, you know, perhaps one of the big metrics that we need to be all focused in globally is how do we meaningfully and measurably closing on the gaps between the haves and the have-nots. You know, to my point earlier about on this side of the pandemic, as we go into the 4th year of the pandemic, there are still massive gaps between the haves and the have-nots. That's part of the reason why I left Pittsburgh and went to the Carolinas in the southeast part of the United States. We see massive, massive gaps, and we're committed with the innovations that we're pushing forward, the ecosystem that we're building to really address head-on the disparities that exist and the gap between the haves and the have-nots. And if we all take on that challenge in the individual communities that we're a part of, I think we get to a meaningful measure.
I agree, and it's always a combination of increasing the average and reducing the deviance. And I think that's kind of a combination we need to take into account. So you touched upon the disparity reduction element of this, which I'm fully subscribed. It was the first project I've ever done in a healthcare system. The minute I went into my first job was to deal with that for several years and try to see what can be done. I've shown some results on the slides today. But increasing averages, I'm asking, and reducing inequalities in what? And that is also something that we need to ask. So nowadays still, patient-reported outcome measures are too seldomly measured and reported and used as a key aspect. And when we say why do we provide care, it's not so that people will not be dead after surgery. Okay, that's important to get out of surgery bed alive. That helps. But that's not the reason someone came in to operate on their knee or to get treatment in a hospital. They actually wanted to get better in running their daily lives in what matters to them. So I think, again, a point that we could use is how can we further measure what's important to patients and try to optimize on that as part of, and reduce inequalities in that.
Right, and incentivize that really.
And incentivize that at the end of the day, yes.
And I'm so glad you made that point, because one of the fallouts from the pandemic has been the number of closures of hospitals because of economic failure in this country. And one of the key predictors of whether or not a hospital-based system failed or survived the pandemic was the demographics of their surrounding catchment area. And if we can't solve this problem in ways that bring more health equality, we're not solving the healthcare problem here or anywhere else. So I think I'm glad you brought that up, and I think that's a good note to close on, is that we cannot succeed in redesigning the system unless we focus more intently on health equality and reducing the inequities that are driven by the social determinants of health. So I want to thank our two panelists. Great conversation. And I think it's time for lunch. Nope. Oops. Okay. Sorry. False alarm.
Yes. You guys can exit stage left.
No, of course we will. All right.
Thanks, guys.
You know, what's interesting is what they ask people to do weight training.
Well done, sir.
Oh, thank you.
Do that. I have 3 children. So we have a couple of things going on. So first of all, just to make sure as we go. And slides, if you can make them go. Your scrubs, you want to make sure, because for today, they're only, okay. Here, you do it. You be in charge. Technical. Multitasking, yeah. Do not forget to get your scrubs printed. So they're over outside of the Innovation Lab in that garden patio. Get that done. For this afternoon, you want to make sure that you have the Bina app downloaded so that you can participate in all the magic.
And try it.
Be ready to go. And next, this afternoon, we have our famous breakout sessions. All of this information, you can take a picture of it, but you will be looking in your email. You're going to get one of the participant communications. It will have all of this, all of these different sessions. And remember, these are folks that have been on the stage yesterday. It gives you an opportunity to go into a deeper dive with each one of them. And so it'll be in the app with all the directions. And if you can go to the next slide, it'll show you a picture. So this is the map. As you've noticed, the Hotel Del has redone a whole host of things here. Beautiful property, and we want to make sure that you get to see some of their new spaces. So the session numbers, if you'll follow that map, and that's all going to be in an email as well as in an app. But go dive into those sessions. Some really, really great time spending with all of the folks that have been up on the stage yesterday and today.
Those start at 1:30, and we'll be back in here specifically at 3 o'clock sharp. So don't miss the start of the 3 o'clock session.
And the weather has not been cooperating so much, so we've had to move our lunch and dinner. And also, it gives us an opportunity to see more of this amazing property. So lunch is going to be in what's called the South Point Center. And again, of course, they give the person who has no sense of direction the task of telling you how to get there. But if you see where we are inside of the entrance to the hotel, we're going to have human wayfinders who they're in the scrubs, so you'll be able to find them, and they're going to lead you over into what's called the South Point Center. That's going to be where lunch and dinner are going to be held tonight. So as soon as we finish up with this, you'll be headed over there. And it's not too far from where the cabana, see where it says the cabanas? That's where most of the breakout sessions are going to be. Other than CareQuest, which is going to be back over in the Hanover room. But for most of you, for breakout sessions, it will be over in that section. You'll notice that we're wearing our Dutch jackets.
Thank you, Lucien.
So we just want to say thank you to the Dutchies who are here. Thank you to Lucien for always organizing and bringing them here. We love you, we adore you, and we want to wear all of the Dutch wear. So do we have any other things that we want to share? Yeah, there's the other map.
Have a great lunch. We'll see you back here at 3 o'clock sharp. Please be on time. Thanks, everybody.